Administration. Appendix PP, Regulation Section 483.70, tags F835 through F851. Begin reading. Tag F835. Section 483.70, Administration. A facility must be administered in a manner that enables it to use its resources effectively and efficiently to attain or maintain the highest practicable physical, mental, and psychosocial well-being of each resident. Guidance Section 483.70. Resources include but are not limited to a facility's operating budget, staff, supplies, or other services necessary to provide for the needs of residents. Procedures Section 483.70. Cite this tag if the actions, inactions, or decisions in administering the facility contributed to deficient practices. The facility's administration is not limited to the administrator and may also include the facility's governing body, management company, and / or others identified by the facility as part of the facility administration. The investigation must demonstrate how the administration knew or should have known of the deficient practice and how the lack of administration involvement contributed to the deficient practice found. When citing this F835, it is not acceptable to simply reiterate the non-compliance from any other associated tags and then refer to this tag. Surveyors must document how the administration knew or should have known of the deficient practice and taken action as appropriate. Tag F836. Section 483.70, A Licensure. A facility must be licensed under applicable state and local law. Section 483.70, Compliance with federal, state, and local laws and professional standards. The facility must operate and provide services in compliance with all applicable federal, state, and local laws, regulations, and codes, and with accepted professional standards and principles that apply to professionals providing services in such a facility. Section 483.70, Relationship to other HHS regulations. In addition to compliance with the regulations set forth in this subpart, facilities are obliged to meet the applicable provisions of other HHS regulations, including but not limited to those pertaining to non-discrimination on the basis of race, color, or national origin. 45 CFR Part 80, non-discrimination on the basis of disability. 45 CFR Part 84, non-discrimination on the basis of age. 45 CFR Part 91, non-discrimination on the basis of race, color, national origin, sex, age, or disability. 45 CFR Part 92, protection of human subjects of research. 45 CFR Part 46, and fraud and abuse. 42 CFR Part 455, and protection of individually identifiable health information. 45 CFR Parts 160 and 164. Violations of such other provisions may result in a finding of non-compliance with this paragraph. Definitions, Section 483.70 AC. Accepted professional standards and principles means federal, state, and local laws, or professional licensure standards. An authority having jurisdiction is the public agency, i.e., federal, state, or local, or official s having the authority to make a determination of non-compliance, and is responsible for providing and signing official correspondence, notifying the facility or professional of their final adverse action. Guidance Section 483.70 AC. This regulation and guidance only applies to actions taken under state licensure authority or other federal HHS agencies as defined in the regulation. It does not include any federal CMS enforcement actions as required at 42 CFR Part Section 488. Procedures, Section 483.70 AC. Facility licenses, permits, and approvals must be provided upon request if necessary to determine compliance with these requirements. Surveyors may not interpret or enforce another agency's requirements if surveyors identify a situation indicating that the facility or any professional providing services may not be in compliance with a state or local law, regulation, code, and / or standard. Refer that information to the authority having jurisdiction for their follow-up action. The Centers for Medicare and Medicaid Services, CMS, Regional Office Row will assist you to contact the appropriate federal agency to refer your concerns. Do not delay a survey waiting for confirmation of receipt from another agency or authority having jurisdiction. If surveyors determined and received confirmation from the authority having jurisdiction that a final adverse action has been taken, then the facility could be found to not meet the requirements at Section 483.70 or C, and a deficiency may be cited here. A final adverse action includes an action imposed by the authority having jurisdiction and is not under appeal or litigation by the facility or the professional providing services in the facility. Do not cite this tag when the authority having jurisdiction has not taken a final adverse action. To simply cite noncompliance with state or local licensure requirements unless final adverse action from the authority having jurisdiction has been confirmed, or as past noncompliance if, at the time of the current survey, the facility or professional is in compliance with the federal, state, or local law, regulation, code, and / or standard, but was found not to be in compliance with those requirements during a time before the current survey. If there is a question, confirm the facility's current compliance status with the authority having jurisdiction. Key elements of noncompliance. To cite deficient practice at F836, the surveyor's investigation will generally show that the facility failed to do any one of the following: hold a current license from the state or other applicable authority to operate as a nursing home, and this information has been verified with the appropriate authority, or provide services in compliance with all applicable federal, state, and local laws, regulations, and codes, and with accepted professional standards and principles that apply to any professional providing services in the facility, whether temporary or permanent. Tag F837. Section 483.70D Governing Body. Section 483.70D1. The facility must have a governing body or designated persons functioning as a governing body that is legally responsible for establishing and implementing policies regarding the management and operation of the facility, and Section 483.70D2, the governing body appoints the administrator who is licensed by the state, where licensing is required. Roman II, responsible for management of the facility, and Roman III, reports to and is accountable to the governing body. Section 483.70D3, the governing body is responsible and accountable for the CAPI program, in accordance with Section 483.75F. Intent Section 483.70D. This regulation is intended to ensure that the facility has an active, engaged, and involved governing body that is responsible for establishing and implementing policies regarding the management of the facility. Definitions, Section 483.70D. Governing body refers to individuals such as facility owner S, chief executive officer S, or other individuals who are legally responsible to establish and implement policies regarding the management and operations of the facility. Guidance. Section 483.70d. The facility must determine a process and frequency by which the administrator reports to the governing body, the method of communication between the administrator and the governing body, including how the governing body responds back to the administrator and what specific types of problems and information, i.e., survey results, allegations of abuse or neglect, complaints, etc., are reported or not reported directly to the governing body, how the administrator is held accountable and reports information about the facility's management and operation, i.e., audits, budgets, staffing, supplies, etc., and how the administrator and the governing body are involved with the facility-wide assessment in Section 483.71, Facility Assessment, at F838. Procedures, Section 483.70d. Request the names and contact information of the members of the governing body at the entrance conference. If there are concerns, conduct an interview with the administrator, and if possible with one or more members of the governing body or designated person as functioning as the governing body. Tag F838. Section 483.71, Facility Assessment. The facility must conduct and document a facility-wide assessment to determine what resources are necessary to care for its residents competently during both day-to-day operations, including nights and weekends and emergencies. The facility must review and update that assessment as necessary and at least annually. The facility must also review and update this assessment whenever there is, or the facility plans for, any change that would require a substantial modification to any part of this assessment. Section 483.71a. The facility assessment must address or include the following. Section 483.71a1. The facility's resident population, including, but not limited to, both the number of residents and the facility's resident capacity. II. The care required by the resident population, using evidence-based, data-driven methods that consider the types of diseases, conditions, physical and behavioral health needs, cognitive disabilities, overall acuity, and other pertinent facts that are present within that population, consistent with and informed by individual resident assessments, as required under Section 483.20. III. The staff competencies and skill sets that are necessary to provide the level and types of care needed for the resident population. IV. The physical environment, equipment, services, and other physical plant considerations that are necessary to care for this population, and any ethnic, cultural, or religious factors that may potentially affect the care provided by the facility, including, but not limited to, activities and food and nutrition services. Section 483.71a2. The facility's resources, including but not limited to the following. All buildings and or other physical structures and vehicles. II. Equipment, medical and non-medical. III. Services provided, such as physical therapy, pharmacy, behavioral health, and specific rehabilitation therapies. IV. All personnel, including managers, nursing, and other direct care staff, both employees and those who provide services under contract, and volunteers, as well as their education and or training, and any competencies related to resident care. Contracts, memorandums of understanding, or other agreements with third parties to provide services or equipment to the facility during both normal operations and emergencies, and Roman 6 health information technology resources, such as systems for electronically managing patient records and electronically sharing information with other organizations. Section 483.7 1A3 a facility-based and community-based risk assessment, utilizing an all-hazards approach as required in Section 483.73A1. Section 483.71B, in conducting the facility assessment, the facility must ensure. Section 483.7 1B1, active involvement of the following participants in the process. I. Nursing home leadership and management, including but not limited to A. Member of the governing body, the medical director and administrator and the director of nursing, and Roman 2 direct care staff, including but not limited to RNs, LPNs/LVNs, NA, and representatives of the direct care staff, if applicable. Roman 3, the facility must also solicit and consider input received from residents, resident representatives, and family members. Section 483.71c, the facility must use this facility assessment to. Section 483.71c1, inform staffing decisions to ensure that there are a sufficient number of staff with the appropriate competencies and skill sets necessary to care for its residents' needs as identified through resident assessments and plans of care as required in 483.3 5A3. Section 483.71c2, consider specific staffing needs for each resident unit in the facility and adjust as necessary based on changes to its resident population. Section 483.71c3, consider specific staffing needs for each shift, such as day, evening, night, and adjust as necessary based on any changes to its resident population. Section 483.71c4, develop and maintain a plan to maximize recruitment and retention of direct care staff. Section 483.71c5, inform contingency, planning for events that do not require activation of the facility's emergency plan, but do have the potential to affect resident care, such as, but not limited to, the availability of direct care nurse staffing or other resources needed for resident care. Intent. The intent of the facility assessment is for the facility to evaluate its resident population and identify the resources needed to provide the necessary care and services the residents require during both day-to-day operations, including nights and weekends and emergencies. Definitions. Competency refers to a measurable pattern of knowledge, skills, abilities, behaviors, and other characteristics in performing that an individual needs to perform work roles or occupational functions successfully. Representative of direct care employees is an employee of the facility or a third party authorized by direct care employees at the facility to provide expertise and input on behalf of the employees for the purposes of informing a facility assessment. Guidance. A facility assessment may be similar to common business practices for strategic and capital budget planning. Strategic planning is an organization's process of defining its strategy or direction and making decisions on allocating its resources to pursue this strategy. However, while a facility may include input from its corporate organization, the facility assessment must be conducted at the facility level. The facility assessment will enable each nursing home to thoroughly assess the needs of its resident population and the required resources to provide the care and services they residents need using evidence-based, data-driven methods. It should serve as a record for staff and management to understand the reasoning for decisions made regarding staffing and other resources and may include the operating budget necessary to carry out facility functions. To ensure the required thoroughness, individuals actively involved in the facility assessment process must include, but are not limited to, the facility's leadership, including a member of the governing body and the medical director, management, including the administrator and the director of nursing, and direct care staff including RNs, LPNs/LVNs, and NAs, the environmental operations manager and other department heads, for example, the dietary manager, director of rehabilitation services, or other individuals should be involved as needed. Additionally, the facility must solicit and consider input from residents, their representatives, family members, and representatives of direct care staff when formulating their assessment. We note there are a variety of ways facilities can solicit this input, such as by distributing a questionnaire related to staffing to residents/families, placing convenient suggestion boxes throughout the facility for anonymous input, or providing annual notices for soliciting input to residents and families prior to conducting the annual review and update of the facility assessment. An assessment of the resident population is the foundation of the facility assessment. Therefore, the assessment must address the resident population, including both the number of residents and the facility's resident capacity. In addition, it must include an evaluation of diseases, conditions, physical and behavioral health needs, cognitive status, acuity of the resident population, and any other pertinent information consistent with resident assessments that may affect and plan for the services the facility must provide, e.g., MDS data. Examples of other pertinent information about the resident population the facility serves may include race, ethnicity, disability, sexual orientation, gender identity, socioeconomic status, preferred language, health literacy, or other factors that affect access to care and health outcomes related to health equity. The assessment of the resident population will also contribute to identifying the physical environment, equipment, medical and non-medical, assisted technology, individual communication devices, or other material resources that are needed to provide the required care and services to residents. The regulation outlines that the individualized approach of the facility assessment is the foundation to determine staffing levels and competencies. Therefore, the facility assessment must include an evaluation of the overall number of facility staff needed to ensure sufficient number of qualified staff are available to meet each resident's needs as identified through resident assessments and care plans. Furthermore, the assessment must include a competency-based approach to determine the knowledge and skills required among staff, including both employees and those who provide services under contract and volunteers, to ensure residents are able to maintain or attain their highest practicable physical, functional, mental, and psychosocial well-being and meet current professional standards of practice. This also includes any ethnic, cultural, or religious factors that may need to be considered to meet resident needs, such as activities, food preferences, nutrition services, and any other aspect of care identified. Finally, the assessment should consider a review of individual staff assignments and systems for coordination and continuity of care for residents within and across these staff assignments, also refer to F835, Section 483.10, Resident Rights. For more information and guidance on cultural competence, the facility must review and update this assessment as necessary, and at least annually, or whenever there is, or the facility plans for, any change that would require a modification to any part of this assessment. For example, if the facility decides to admit residents with care needs who were previously not admitted, such as residents on Ventilators or dialysis, the facility assessment must be reviewed and updated to address how the facility staff, resources, physical environment, etc., meet the needs of those residents and any areas requiring attention, such as any training or supplies required to provide care. Additionally, the facility must consider specific staffing needs for each shift, e.g., day, evening, night, weekend shifts, and for each resident unit in the facility based on changes to resident population. The assessment must include or address an evaluation of the facility's training program to ensure any training needs are met for all new and existing staff, including managers, nursing, and other direct care staff, individuals providing services under a contractual arrangement, and volunteers consistent with their expected roles. The assessment should also include an evaluation of what policies and procedures may be required in the provision of care and that these meet current professional standards of practice. If there are any concerns regarding training, refer to Section 483.95, Training. The facility assessment must be used to develop and maintain a plan to maximize direct care staff recruitment and retention. The facility assessment must include an evaluation of any contracts, memorandums of understanding including third-party agreements for the provision of goods, services, or equipment to the facility during both normal operations and emergencies. The facility assessment must address their process for overseeing these services and how those services will meet resident needs and regulatory, operational, maintenance, and staff training requirements. For example, if the facility contracts for language translation, the assessment must address how those contractors will ensure services are provided both during normal operational hours and during emergencies. The facility assessment must consider health information technology resources, such as managing resident records and electronically sharing information with other organizations. For example, the assessment should address how the facility will securely transfer health information to a hospital, home health agency, or other providers for any resident transferred or discharged from the facility. The facility assessment must include an evaluation of the physical environment necessary to meet the needs of the residents. This must include an evaluation of how the facility needs to be equipped and maintained to protect and promote the health and safety of residents. This should also include an evaluation of building maintenance capital improvements or structures, vehicles, or medical and non-medical equipment and supplies. The facility assessment must be used to create a contingency plan for events that do not require the activation of the facility emergency plan, but have the potential to impact resident care, such as the availability of direct care nurse staffing or other resources needed for care of residents. For example, the use of contract licensed nurses to cover several shifts during a holiday. The facility-based and community-based risk assessment, utilizing an all-hazards approach, must evaluate the facility's ability to maintain continuity of operations and its ability to secure required supplies and resources during an emergency or natural disaster. For example, if the facility is located in a flood zone, the risk assessment must include an evaluation of how residents will be kept safe and needs met during a flood affecting the facility. Facility staff should consider involving their local/county office of emergency preparedness when conducting this community-based risk assessment. The facility's emergency preparedness plans, as required under Section 483.73, A1, should be integrated and compatible with the facility assessment. As one is updated, so should the other. Risk assessment is general terminology that is within the emergency preparedness regulations and preamble to the final Rule 81 Fed. Reg. 63860, Sept. 16, 2016, which describes a process facilities are to use to assess and document potential hazards within their areas and the vulnerabilities and challenges which may impact the facility. Additional terms currently used by the industry are all hazards risk assessments, also referred to as hazard vulnerability assessments, HVA, or all hazards self-assessments. For the purposes of these guidelines, we are using the term risk assessment, which may include a variety of current industry practices used to assess and document potential hazards and their impacts. Hazard vulnerability assessments, HVA, are systematic approaches to identifying hazards or risks that are most likely to have an impact on a healthcare facility and the surrounding community. The HVA describes the process by which a provider or supplier will assess and identify potential gaps in its emergency plans. Potential loss scenarios should be identified first during the risk assessment. Once a risk assessment has been conducted and a facility has identified the potential hazards/risks they may face, the organization can use those hazards/risks to conduct a business impact analysis. This guidance is not specifying which type of generally accepted emergency preparedness risk assessment facilities should have, as the language used in defining risk assessment activities is meant to be easily understood by all providers and suppliers that are affected by this final rule and is aligned with the National Preparedness System and Terminology 81 Fed. Reg. 63860 at 63875. However, facilities are expected to conduct a full assessment of hazards based on geographical location and the individual facility dynamics, such as patient population, investigative procedures. Surveyors determine whether a facility assessment contains the required components under the regulation. However, they should not evaluate the quality of the assessment if systemic care concerns are identified that are related to the facility's planning. Review the facility assessment to determine if these concerns were considered as part of the facility's assessment process. For example, if a facility recently started accepting bariatric residents and concerns are identified related to providing bariatric services, did facility staff update its assessment before accepting residents with these needs to identify the necessary equipment, staffing, etc., needed to provide care that is effective and safe for the residents and staff? Questions surveyors should consider include, but are not limited to, the following. Does the facility assessment include an evaluation of the resident population and its needs, e.g., acuity based on evidence-based, data-driven methods? Does this reflect the population observed? Does it address the facility's resident capacity? Does the facility assessment include information on the staffing levels needed for specific shifts, such as day, evening, and night, and adjusted as necessary based on changes to resident population? Does the facility assessment address what skills and competencies are required by those providing care? Was the facility assessment conducted with input from the individuals stated in the Regulation 483.71b? Does the facility assessment indicate what resources, including but not limited to equipment, supplies, services, personnel, health, information technology, and physical environment are required to meet all resident needs? Does the facility have a plan for maximizing recruitment and retention of direct care staff? Does the facility assessment include a contingency plan that is informed by the facility assessment? Key elements of noncompliance. To cite deficient practice at F838, the surveyor's investigation will generally show that The facility failed to do any one of the following: annually and as necessary, conduct, document, review, and update a facility-wide assessment, or address or include in the facility assessment the minimum requirements as described in Section 483.71a, b, and c. Potential tags for additional investigation. If the survey investigation reveals that there are not sufficient or competent staff, refer to F839, Section 483.21b3, Comprehensive Person-Centered Care Planning. F825 or 726, Section 483.35a, C for any nursing services not related to behavioral health care or dementia care. F841, Section 483.40, for any staff caring for residents with dementia or a history of trauma and or post-traumatic stress disorder. F801, Section 483.60a for food and nutrition staff. F826, Section 483.65b, specialized rehabilitative services. F839, Section 483.70e, staff qualifications. F837, Section 483.70d, governing body. F865, Section 483.75, CAPI/CA and A. Deficiency examples. One of the sampled residents had experienced a fall while staff were transferring them from the bed to a chair as a result of a faulty mechanical lift. The resident's care plan indicates requiring a 2-person assist using a mechanical lift. After the fall, the resident was evaluated, and although he did not suffer any physical harm, upon interview, he did express psychological harm and stated he was afraid of using these lifts and would prefer to remain in bed. Interviews with direct care. Staff indicated that many of the lifts are old, in frequent need of repair, and often malfunction when used. A review of the current facility assessment did not include or address equipment necessary to provide for the needs of residents and did not have active involvement of direct care staff in the process. The facility recently admitted several individuals, some that follow a vegan diet, and others that follow the Judaism faith, both of which include dietary restrictions. These individuals did not previously reside in the facility and represents a substantial change in the resident population. The residents expressed concerns that they are not always able to choose foods that are consistent with their cultural beliefs. Upon review of the facility assessment, the facility did not review and update their assessment based on this change in their resident population. As a result, the facility did not adjust the menus for these newly admitted residents. When reviewing the facility assessment, the survey team identified that while the assessment included all the required components, it had not been reviewed for any potential updates in the last 15 months. Facilities are required to review and update the assessment as necessary, and at least annually, even though there were no changes to resident needs, staffing, or other resources. The facility's failure to review the assessment within 12 months may result in the facility failing to identify a factor that would require a change to the assessment, thereby potentially placing the residents at risk for at least minimal harm. Tag F839. Section 483.70e, staff qualifications. Section 483.70e1. The facility must employ on a full-time, part-time, or consultant basis those professionals necessary to carry out the provisions of these requirements. Section 483.70e2. Professional staff must be licensed, certified, or registered in accordance with applicable state laws. Definitions. Section 483.70e. Licensed health professional, as defined at Section 483.5, is a physician, physician assistant, nurse practitioner, physical, speech, or occupational therapist, physical or occupational therapy assistant, registered professional nurse, licensed practical nurse, or licensed or certified social worker, or registered respiratory therapist, or certified respiratory therapy technician. Procedures, Section 483.70e. If there is reason to doubt the qualifications or competencies of any personnel, including temporary, agency, and contracted individuals, verify qualifications with the appropriate state registry or practitioner professional licensing body. If the survey investigation reveals that there are concerns with the qualifications or competencies of activities, professionals refer to F835, Section 483.2, 4C2. Nursing staff refer to F726, Section 483.35. Any staff caring for residents with dementia or a history of trauma and or post traumatic stress disorder refer to F741, Section 483.40. Food and nutrition staff refer to F801, Section 483.60a. Individuals providing specialized rehabilitative services refer to F826, Section 483.65b. Social workers refer to F850, Section 483.700. Note, only cite F839 for any staff not referenced above or if any professional staff is not licensed, certified, or registered in accordance with applicable state laws. This includes any physician or practitioner, including the medical director, that does not hold a valid license to practice in the state where the nursing home is located. If a facility has not designated a physician to serve as a medical director, refer that citation under F841. Tag F840. Section 483.70F, use of outside resources. Section 483.70F1, if the facility does not employ a qualified professional person to furnish a specific service to be provided by the facility must have that service furnished to residents by a person or agency outside the facility under an arrangement described in Section 1860, 1W of the Act, or with respect to services furnished to NF residents and dental services furnished to SNF residents an agreement described in paragraph G2 of this section. Section 483.70 F2 arrangements as described in Section 1860, 1W of the Act or agreements pertaining to services furnished by outside resources must specify in writing that the facility assumes responsibility for obtaining services that meet professional standards and principles that apply to professionals providing services in such a facility, and Roman II, the timeliness of the services. Definitions, Section 483.70F. Timeliness means that services are completed and results are provided within the timeframe S specified in accordance with facility policies and procedures, the medical orders or professional standards of practice, and that facility staff notifies the residents, physician, dentist, physician assistant, nurse practitioner, or clinical nurse specialist as directed in the medical order. Tag F841. Section 483.70G Medical Director. Section 483.70G1. The facility must designate a physician to serve as medical director. Section 483.70G2. The medical director is responsible for Implementation of resident care policies, and Romans 2, the coordination of medical care in the facility. Definitions, Section 483.70G. Medical director means a physician who oversees the medical care and other designated care and services in a healthcare organization or facility. Under these regulations, the medical director is responsible for coordinating medical care and helping to implement and evaluate resident care policies that reflect current professional standards of practice. Physician/practitioner, physician assistant, nurse practitioner, clinical nurse. Specialist means the individual who has responsibility for the medical care of a resident. Current professional standards of practice refers to approaches to care, procedures, techniques, treatments, etc., that are based on research and/or expert consensus and that are contained in current manuals, textbooks, or publications, or that are accepted, adopted, or promulgated by recognized professional organizations or national accrediting bodies. Resident care policies refers to the facility's overall goals, directives, and governing statements that direct the delivery of care and services to residents consistent with current professional standards of practice. Guidance Section 483.70G. If the medical director does not hold a valid license to practice in the state where the nursing home is located, refer to F839 Section 483.70E staff qualifications. The facility must designate a physician to serve as medical director, unless waived per Section 488.5 6B by CMS. The facility must identify how the medical director will fulfill his or her responsibilities to effectively implement resident care policies and coordinate medical care for residents in the facility. This may be included in the medical director's job description or through a separate facility policy. Facilities and medical directors have flexibility on how all the duties will be performed. However, the facility must ensure all responsibilities of the medical director are effectively performed, regardless of how the task is accomplished or the technology used, to ensure residents attain or maintain their highest practicable physical, mental, and psychosocial well-being. For example, some, but not all, duties may be conducted remotely using various technologies, e.g., phone, email, fax, telehealth, etc., that is compliant with all confidentiality and privacy requirements. It is important that the medical director's responsibilities require that he/she be knowledgeable about current professional standards of practice in caring for long-term care residents and about how to coordinate and oversee other practitioners. If the medical director is also an attending physician, there should be a process to ensure there are no concerns with the individual's performance as a physician, i.e., otherwise, the medical director is monitoring his or her own performance. If there are concerns regarding his or her performance, the facility's administration should have a process for how to address these situations. While medical directors who work for multi-facility organizations, such as corporate or regional offices, may be involved in policy development, the facility's individual policies must be based on the facility's unique environment and its residents' needs, and not based on a broad, multi-facility structure. Although the medical director is not required to sign policies, the facility must be able to show that the development, review, and approval of resident care policies included his or her input. Medical director responsibilities must include their participation in administrative decisions, including recommending, developing, and approving facility policies related to residents' care. Resident care includes the residents' physical, mental, and psychosocial well-being. Issues related to the coordination of medical care identified through the facilities. Quality assessment and assurance committee and other activities related to the coordination of care, organizing and coordinating physician services and services provided by other professionals as they relate to resident care. Participate in the quality assessment and assurance committee or assign a designee to represent him/her. Refer to F835. Note, having a designee does not change or absolve the medical director's responsibility to fulfill his or her role as a member of the QAA committee, or his or her responsibility for overall medical care in the facility. In addition, the medical director responsibilities should include, but are not limited to, ensuring the appropriateness and quality of medical care and medically related care, assisting in the development of educational programs for facility staff and other professionals, working with the facility's clinical team to provide surveillance and develop policies to prevent the potential infection of residents. Refer to infection control requirement at Section 483.80. Cooperating with facility staff to establish policies for assuring that the rights of individuals, residents, staff members, and community members are respected. Supporting and promoting person-directed care, such as the formation of advance directives, end-of-life care, and provisions that enhance resident decision-making, including choice regarding medical care options, identifying performance expectations, and facilitating feedback to physicians and other healthcare practitioners regarding their performance and practices, discussing and intervening as appropriate with a healthcare practitioner regarding medical care that is inconsistent with current standards of care, and assisting in developing systems to monitor the performance of the healthcare practitioners, including mechanisms for communicating and resolving issues related to medical care and ensuring that other licensed practitioners, e.g., nurse practitioners who may perform physician-delegated tasks, act within the regulatory requirements and within the scope of practice as defined by state law. Procedures Section 483.70G. If a deficiency has been identified regarding a resident's care, also determine if the medical director had knowledge or should have had knowledge of a problem with care, or physician services, or lack of resident care policies and practices that meet current professional standards of practice and failed to get involved or to intercede with other physicians or practitioners in order to facilitate and/or coordinate medical care and/or to provide guidance for resident care policies. Interview the medical director about his or her involvement in assisting facility staff with resident care policies, medical care, and physician issues. Understanding of his or her roles, responsibilities, and functions, and the extent to which he/she receives support from facility management for these roles and functions. Process for providing feedback to physicians and other healthcare practitioners regarding their performance and practices, including discussing and intervening as appropriate with a healthcare practitioner regarding medical care that is inconsistent with current professional standards of care. Input into the facility's scope of services, including the capacity to care for residents with complex or special care needs, such as dialysis, hospice, or end-of-life care, respiratory support with ventilators, intravenous medications/fluids, dementia and/or related conditions, or problematic behaviors or complex mood disorders. His or her participation or involvement in conducting the facility assessment and the quality assessment and assurance committee. Interview facility leadership, e.g., administrator, director of nursing, and others as appropriate about how they interact with the medical director related to the coordination of medical care, the facility's clinical practices and concerns or issues with other physicians or practitioners. Also, refer to Section 483.30, Physician Services, for more information. Key elements of noncompliance. To cite deficient practice at F841, the surveyor's investigation will generally show that the facility failed to do any of the following: designate a physician to serve as medical director, or ensure the medical director fulfilled his or her responsibility for the implementation of resident care policies or the coordination of medical care in the facility. Deficiency categorization. An example of Level 4, immediate jeopardy to resident health and safety, includes, but is not limited to: the facility's medical director was aware of and did not intervene when a healthcare practitioner continued over several months to provide inappropriate medical care for infection prevention to a resident that was inconsistent with current professional standards of care. As a result, this resident's health continued to decline and was hospitalized with a severe infection. An example of Level 3, actual harm physical or psychological that is not immediate jeopardy, includes, but is not limited to: the director of nursing repeatedly requested the medical director's assistance in coordinating medical care with attending physicians for residents receiving psychotropic medications. In particular, there were several physicians who had a known history of failing to provide justification for continued use of these medications and not attempting a gradual dose reduction for the residents under his or her care. As a result of the medical director's failure to intervene, several residents continued to receive these medications without medical/clinical justification, based on record review and interviews with residents, their representatives, and staff. There was no supporting evidence to indicate that an immediate jeopardy situation existed. However, due to the continuation of the use of these psychotropic medications, the residents withdrew from activities and from eating in the dining room. This caused decreased appetite and substantial weight loss for several residents. Actual harm, both physical and psychosocial, was indicated. Unnecessary medications was also cited for not ensuring the residents were receiving the lowest dose possible. An example of Level 2, no actual harm with a potential for more than minimal harm that is not immediate jeopardy, includes but is not limited to: the administrator had made multiple requests for the medical director to meet with physicians to ensure that they were familiar with the facility's resident care policies. At the time of the survey, the medical director was interviewed and stated that she had not yet had an opportunity to introduce herself to or meet with physicians, although no actual harm occurred due to the medical director's failure to ensure implementation of resident care policies. The potential for more than minimal harm existed. Level 1 severity. 1 does not apply for this regulatory requirement. Tag F842. Section 483.20 F5 Resident Identifiable Information. A facility may not release information that is resident identifiable to the public. Roman 2. The facility may release information that is resident identifiable to an agent only in accordance with a contract under which the agent agrees not to use or disclose the information, except to the extent the facility itself is permitted to do so. Section 483.70 H Medical Records. Section 483.70 H1. In accordance with accepted professional standards and practices, the facility must maintain medical records on each resident that are complete. Roman 2. Accurately documented. Roman 3. Readily accessible. And Roman 4. systematically organized. Section 483.70H2. The facility must keep confidential all information contained in the residence records, regardless of the form or storage method of the records, except when release is to the individual or their resident representative where permitted by applicable law. Roman II, required by law. Roman III, for treatment, payment, or healthcare operations, as permitted by and in compliance with 45 CFR 164.506. Roman IV, for public health activities, reporting of abuse, neglect, or domestic violence, health oversight activities, judicial and administrative proceedings, law enforcement purposes, organ donation purposes, research purposes, or to coroners, medical examiners, funeral directors, and to avert a serious threat to health or safety as permitted by and in compliance with 45 CFR 164.512. Section 483.70H3. The facility must safeguard medical record information against loss, destruction, or unauthorized use. Section 483.70H4. Medical records must be retained for the period of time required by state law, or Roman II, 5 years from the date of discharge, when there is no requirement in state law, or Roman III, for minor, 3 years after a resident reaches legal age under state law. Section 483.70H5. The medical record must contain sufficient information to identify the resident. Roman II, a record of the resident's assessments. Roman III, the comprehensive plan of care and services provided. Roman IV, the results of any pre-admission screening and resident review evaluations and determinations conducted by the state. Physician, nurse, and other licensed professionals' progress notes, and Roman VI, laboratory, radiology, and other diagnostic services reports as required. Under Section 483.50. Guidance Section 483.70H. The medical record shall reflect a resident's progress toward achieving their person-centered plan of care objectives and goals, and the improvement and maintenance of their clinical, functional, mental, and psychosocial status. Staff must document a resident's medical and non-medical status when any positive or negative condition change occurs. At a periodic reassessment and during the annual comprehensive assessment, the medical record must also reflect the resident's condition and the care and services provided across all disciplines to ensure information is available to facilitate communication among the interdisciplinary team. The medical record must contain an accurate representation of the actual experiences of the resident and include enough information to provide a picture of the resident's progress, including his or her response to treatments and or services, and changes in his or her condition, plan of care goals, objectives, and or interventions. Except for the annual comprehensive assessment, periodic reassessments when a significant change in status occurs, and quarterly monitoring assessments, regulations do not define the documentation frequency of a resident's progress. Professional standards of practice, however, suggests documentation include a resident's care plan. Implementation progress. Resident Assessment Instrument, RI data, is part of a resident's medical record and is protected from improper disclosure by facilities under current federal law. Facilities are required by Section 1819 C1A Roman IV and 1919 C1A Roman IV of the Act, and Section 483.70 H2 and H3 to keep confidential all information contained in the resident's medical record and to maintain safeguards against the unauthorized use of a resident's information. regardless of the storage method of the records. At Section 483.20 F5, Resident Identifiable Information, it requires that a facility may not release information that is resident identifiable to the public, and that the facility may release information that is resident identifiable to an agent only in accordance with a contract under which the agent agrees not to use or disclose the information except to the extent the facility itself is permitted to do so, if a deficiency is identified related to this. Regulations cite the deficient practice here at F842. Electronic health records, AR facilities using an electronic format for medical or other resident documentation, for example, documenting progress notes, medication administration, electronic claims filing, etc., must comply with the Health Insurance Portability and Accountability Act, HIPAA Privacy and Security Rules, 45 CFR Parts 160 and 164. Surveyors are not responsible for assessing compliance with these rules. The Department of Health and Human Services Office for Civil Rights has primary responsibility for enforcing the HIPAA privacy and security rules. The surveyor's responsibility is to assess compliance with the regulatory requirement for maintaining the content and confidentiality of the medical record. If there are concerns that the facility's practice may constitute violations of the HIPAA privacy or security rules, refer these concerns to HHS Office for Civil Rights. The facility is responsible for ensuring the backup of data and security of information. CMS encourages the development of systems that permit appropriate sharing of clinical information across providers if the development of such systems is fully consistent with the requirement for protecting the confidentiality of the medical record. Surveyors should not evaluate the features of the EHR system. Instead, focus on how the EHR system is being used in the facility. Use of electronic signatures. Electronic signatures are acceptable whether or not the record is entirely electronic. If a facility uses these signatures, they must have policies that identify those individuals who are authorized to sign electronically and describe the security safeguards to prevent unauthorized use of these signatures. Such security safeguards include, but are not limited to, the following: built-in safeguards to minimize the possibility of fraud, that each staff responsible for an attestation has an individualized identifier. The date and time is recorded from the computer's internal clock at the time of entry. An entry is not to be changed after it has been recorded, and the computer program controls what sections/areas any individual can access or enter data based on the individual's personal identifier and, therefore, his or her level of professional qualifications. When rubber stamp signatures are authorized by the facility's management, the individual whose signature the stamp represents shall place in the administrative offices of the facility a signed statement to the effect that she is the only one who has the stamp and uses it. A list of computer codes and written signatures must be readily available and maintained under adequate safeguards. Refer to Section 483.30b Physician visits for additional guidance. Investigative Procedures Section 483.70H. When reviewing a resident's medical record, determine if the record, including any archived information, is accessible to and provides sufficient information for appropriate staff to respond to the changing status and needs of the resident. For example, does the medical record provide sufficient information for staff to respond to the changing status and needs of the resident? How does the facility ensure medical records are accessible to staff? How does the facility handle the archiving of documentation? Interview facility staff to determine the facility's policies and practice for maintaining. Confidentiality of residents' records. Concerns regarding medical record confidentially. Storage, including archiving, should be reviewed under this tag. Determine through observations, record review and interviews. How facility staff ensure confidentiality of resident records. If there is a problem with confidentiality, is it systematic? That is, does the problem lie in the record-keeping system or with a staff person's use of records, e.g., leaving records in a place easily accessible to residents, visitors, or other unauthorized persons? Are computer screens showing information left unattended and readily observable, or accessible by others not authorized to view this information? Are there documents publicly posted such as passwords or other information, which could be evidence of non-compliance with confidentiality? Use of electronic records in the survey process. There are no requirements for the use of electronic health record AIR systems. However, if a facility uses an EHR system, it must grant access to the survey team timely, i.e., before the end of the first day of the survey, if access to an EHR is required by the surveyor. The facility will A. Provide the surveyor with instructions, guidance, or information on how to use its EHR system, and B. Designate an individual who will, when requested by the surveyor, access the system, respond to any questions, or assist the surveyor as needed in a timely fashion. The facility must make available to surveyors upon their request a printout of any record or part of a record. Surveyors should only request printed copies when needed to support a potential deficient practice, or if additional information is needed that is not contained the AIR. If facility staff impedes the survey process by purposefully or unnecessarily delaying or restricting access to records, this may lead to non-compliance and potential enforcement actions. If this situation occurs, surveyors should contact their supervisors, and if needed, they would then contact the CMS regional office for assistance. Key elements of non-compliance. To cite deficient practice at F842, the surveyor's investigation will generally show that the facility failed to do any of the following. Ensure resident identifiable information was not released to the public or any unauthorized entity as stated in Section 483.20 F5 Roman 2, or ensure that any resident identifiable information released to an agent was to an agent in accordance with a contract under which the agent agreed not to disclose any information the facility would not also be able to release publicly, or maintain medical records on each resident in accordance with accepted professional standards and practices that are complete, accurately documented, readily accessible, and systematically organized. Keep all information in the resident's records confidential, except when release is to the resident or resident representative where permitted by applicable law, or required by law, or for treatment, payment, or healthcare operations permitted and in compliance with 45 CFR Section 164.512, or allowed under the conditions of Section 483.70 H2 Roman 4. Safeguard medical record information against loss, destruction, or unauthorized use, or retain medical records for the period of time required by state law, or 5 years from the date of discharge when there is no requirement in state law, or 3 years after a minor resident reaches legal age under state law, or ensure the medical record contained sufficient information to identify the resident, a record of the resident's assessments, the comprehensive plan of care and services provided, O. The results of the pre-admission PASAR level 1 screening and subsequent evaluations and determinations. O. Physicians, nurses, and other licensed professionals' progress notes, or O. Laboratory, radiology, and other diagnostic service reports. Tag F843. Section 483.7, 0I Transfer Agreement. Section 483.70I1. In accordance with Section 1861L of the Act, the facility other than a nursing facility, which is located in a state on an Indian reservation, must have in effect a written transfer agreement with one or more hospitals approved for participation under the Medicare and Medicaid programs that reasonably assures that I residents will be transferred from the facility to the hospital and ensured of timely admission to the hospital when transfer is medically appropriate as determined by the attending physician or, in an emergency situation, by another practitioner in accordance with facility policy and consistent with state law and Roman II, medical, and other information needed for care and treatment of residents. And, when the transferring facility deems it appropriate, for determining whether such residents can receive appropriate services or receive services in a less restrictive setting than either the facility or the hospital, or reintegrated into the community, will be exchanged between the providers, including but not limited to the information required under Section 483.1, 5C2 Roman 3. Section 483.7, 0I2. The facility is considered to have a transfer agreement in effect if the facility has attempted in good faith to enter into an agreement with a hospital sufficiently close to the facility to make transfer feasible. Guidance Section 483.70I. A facility must demonstrate its good faith effort to secure a transfer agreement with a hospital if a hospital that the facility reached out to refuses to accept a transfer agreement. Determine if the facility reached out to any other hospitals. A good faith effort is considered to have been made if the nursing home has exhausted all reasonable means and taken every necessary and appropriate step to enter into an agreement with a hospital sufficiently close to the facility to make the transfer of residents safe and orderly. Also refer to Section 483.15, Admission, Transfer and Discharge Rights. Information in the transfer agreement should support the requirements in Section 483.15C, F835, and the facilities. Efforts to ensure safe and orderly transfers. In addition, the agreement should include the information in Section 483.1, 5C2 Roman 3, and consider other information that may be necessary for the safe and orderly transfer of the resident and care and treatment of the resident at the receiving setting. Key elements of noncompliance. To cite deficient practice at F843, the surveyor's investigation will generally show that the facility failed to do any one of the following: have a written transfer agreement in effect with one or more hospitals approved for participation in Medicare/Medicaid programs, or ensure the transfer agreement tests reasonably assured. O. Residents will be transferred for timely admission to the hospital when medically appropriate, or O. Medical or other information will be exchanged between the facility and the hospital, including but not limited to the information required under Section 483.1, 5C2 Roman 3, or information needed for resident care/treatment, or to determine whether the resident can be cared for in a less restrictive setting than either the facility or the hospital, or attempt good faith efforts to enter into an agreement with a hospital sufficiently close to the facility to make the transfer safely and orderly. Tag F844. Section 483.7, 0J disclosure of ownership. Section 483.7, 0J1, the facility must comply with the disclosure requirements of Section 420.206 and 455.104 of this chapter. Section 483.7, 0J2, the facility must provide written notice to the state agency responsible for licensing the facility at the time of change, if a change occurs in I persons with an ownership or control interest, as defined in Section 420.201 and 455.101 of this chapter. Roman II, the officers, directors, agents, or managing employees. Roman III, the corporation, association, or other company responsible for the management of the facility, or Roman IV, the facility's administrator or director of nursing. Section 483.7, 0J3, the notice specified in paragraph J2 of this section must include the identity of each new individual or company. The following hyperlinks are included for surveyor reference only. 42 CFR Section 420.20, 1 Disclosure of ownership and control. Definitions. 42 CFR Section 420.206, Disclosure of persons having ownership, financial, or control. Interest. 42 CFR Section 455.10, 1 Disclosure of information by providers and fiscal agents. Definitions. 42 CFR Section 455.104, Disclosure by Medicaid providers and fiscal agents. Information on ownership and control. Tag F845. Section 483.7, 0K Facility Closure Administrator. Any individual who is the administrator of the facility must. Section 483.7, 0K1, submit to the state survey agency, the state LTC ombudsman, residents of the facility, and the legal representatives of such residents or other responsible parties, written notification of an impending closure. At least 60 days prior to the date of closure, or Roman II, in the case of a facility where the secretary or a state terminates the facilities. Participation in the Medicare and or Medicaid programs, not later than the date that the secretary determines appropriate. Section 483.7, 0K2, ensure that the facility does not admit any new residents on or after the date on which such written notification is submitted, and Section 483.7, 0K3 include in the notice the plan that has been approved by the state for the transfer and adequate relocation of the residents of the facility by a date that would be specified by the state prior to closure, including assurances that the residents would be transferred to the most appropriate facility or other setting. Terms of quality, services, and location, taking into consideration the needs, choice, and best interests of each resident. Guidance Section 483.70K. The closure plan is developed when a facility knows it is closing or upon involuntary termination of the Medicare/Medicaid provider agreement. The closure plan should be based on policies and procedures as required by Section 483.70L. An individual serving as the administrator of a skilled nursing facility, SNF, nursing facility, NF, or duly participating facility, SNF/NF, must provide written notification of an impending closure of a facility, which also includes the plan for relocation of residents at least 60 days prior to the impending closure, or, if the secretary terminates the facility's participation in Medicare or Medicaid, not later than the date the secretary determines appropriate. Notice must be provided to the state survey agency, the state long-term care ombudsman state LTC, all the residents of the facility, and the legal representatives of residents or other responsible parties. An impending closure does not include events that may result in a temporary closure, resulting from a local, regional, state, or national emergency situation, such as a fire, hurricane, or tornado. In some cases, an administrator may not have direct control over an impending closure and implementing the facility's written notice and closure plans and procedures. 4. Example, an administrator may be hired to oversee the facility's impending closure, and she was not present when the decision was made to close the facility, or the administrator was employed less than 60 days prior to impending closure. However, this does not relieve the current administrator from implementing or developing the plans, procedures, and providing notifications as required. In this example, the administrator must provide the closure notice and plan as soon as possible and begin implementing the plans for closure, working with the state survey agency for the orderly and safe transfer, discharge, and relocation of all residents. The new administrator or other temporary manager hired to assist with the facility closure must develop and or implement the closure plans and work closely with the state survey agency and CMS regional office, CMS row, to ensure that appropriate procedures are implemented. In a situation in which notice requirements were not met by the previous or current administrator, the state survey agency and the CMS RO may take action against the administrator as permitted under Section 488.446. Refer to Chapter 7 of the State Operations Manual for more information on enforcement actions in these situations. For all impending closures, the facility needs to submit its closure plan to the state survey agency for review and approval. The closure plan must contain the information necessary to identify the steps for a safe and orderly facility closure, including the transfer, discharge, or relocation of all residents, and identify the individuals responsible for ensuring the plans and procedures are successfully carried out. If CMS or the state Medicaid agency involuntarily terminates the facility's participation in the Medicare and or Medicaid programs, the facility's notifications must be no later than the date specified by CMS or the state Medicaid agency. Notice must still be given. If the facility remains open, but CMS or the state Medicaid agency involuntarily terminates the facility's participation in the Medicare and or Medicaid programs. In addition, the administrator or someone acting on behalf of the administrator should notify in writing, prior to the impending closure of the facility, the facility's medical director, resident's primary physician, CMS regional office row, and state Medicaid agency. Although not required, facilities are encouraged to provide notice to other entities that are impacted, such as employees, union representatives, vendors, community partners, hospitals, home health agencies, dialysis facilities, and other providers as early as possible. The facility's notifications should be developed with input from the facility's medical director and other management staff, and include details from the closure plan for the safe and orderly transfer, discharge, or adequate relocation of all residents. In addition to written notification, facility staff should discuss this information with residents, their families, and or legal representatives in order to provide a better understanding of the closure and their rights. Notice of facility closure to residents and their legal or other responsible parties must be provided in a language and manner they understand. Facility staff should make every possible effort to lessen transfer trauma for residents, which may include reviewing the residents' care routines, needs, and preferences with staff at the receiving facility who will be caring for the resident, and assisting residents and/or their representatives with obtaining information. Required to make an informed decision about facility relocation. Also refer to Section 483.1, 5C transfer and discharge requirements. The notice must include the name, address, and telephone number of the state LTC ombudsman. For residents with developmental disabilities, the mailing address and telephone. Number of the agency responsible for the protection and advocacy of developmentally disabled individuals established under Part C of the Developmental Disabilities Assistance and Bill of Rights Act, and for residents with mental illness, the mailing address and telephone number of the agency responsible for the protection and advocacy of individuals with mental illness established under the Protection and Advocacy for Mentally Ill Individuals Act. In addition, the notice should include contact information for the primary facility, contact responsible for the daily operation and management of the facility during the facility's closure process. Key elements of noncompliance. To cite deficient practice at F845, the surveyor's investigation will generally show that the facility failed to do any one of the following: provide prior notice of an impending closure to the appropriate parties as required, or ensure no new residents continued to be admitted to the facility on or after the date of the notice of impending closure was submitted, or ensure residents were transferred, discharged, or relocated to the most appropriate and available facility or other setting in terms of quality, services, and location, taking into consideration the needs, choice, and best interests of each resident. Tag F846. Section 483.7, 0L Facility Closure. The facility must have in place policies and procedures to ensure that the administrator's duties and responsibilities involve providing the appropriate notices. In the event of a facility closure, as required at paragraph L of this section. Guidance Section 483.70L. Policies and procedures must be in place at all times in order to be used in the case of a facility closure or in case of termination of a facility's Medicare and/or Medicaid provider agreement in order to meet the requirements of Section 483.70K. The policies and procedures must address the administrator's duties and responsibilities as required per Section 483.70K4. Submitting a closure plan and providing timely written notice to the state survey agency, the state LTC ombudsman, residents of the facility, and the legal representatives of residents or other responsible parties, including the CMS, Regional Office Row, the state Medicaid agency, and staff responsible for providing care and services to residents. How facility staff will identify available settings in terms of quality, services, and location by taking into consideration each resident's individual needs, choices, and best interests. The facility may not close until all residents are transferred, relocated, or discharged in a safe and orderly manner to the most appropriate setting, and assurance that no new residents will be admitted to the facility on or after the date that the written notice of impending closure was provided to the state survey agency. To ensure resident safety during a facility closure or termination of a facility's Medicare and/or Medicaid provider agreement, the policies and procedures should also address how facility staff will ensure that all pertinent information about each resident is communicated to the receiving provider in accordance with Section 483.1, 5C2 Roman 3. And each resident's complete medical record information, including archived files. minimum data set MDS assessments, and all orders, recommendations, or guidelines from the resident's attending physician. In addition to the administrator, the primary contact tests responsible for the daily operation and management of the facility during the facility's closure process. The roles and responsibilities of the facility's owners, administrator, or their replacement tests or temporary managers/monitors during the closure process, and their contact information. Provisions for ongoing operations and management of the facility and its residents and staff during the closure process that include payment of salaries and expenses to staff, vendors, contractors, etc. Continuation of appropriate staffing and resources to meet the needs of each resident, including the provision of medications, services, supplies, and treatments as ordered by the resident's physician/practitioner. Ongoing accounting, maintenance, and reporting of resident personal funds. And labeling, safekeeping, and appropriate transfer of residents' personal belongings, such as clothing, medications, furnishings, etc., at the time of transfer or relocation, including contact information for missing items after the facility has closed. The facility's policies and procedures should also consider certain provisions to prepare residents to ensure a safe and orderly transfer from the facility. These provisions include, but are not limited to, interviewing residents and their legal or other responsible parties to determine each resident's goals, preferences, and needs in planning for the services, location, and setting to which they will be moved, offering each resident in a manner and language understood by the resident the opportunity to obtain information regarding their community options, including setting and location, providing residents with information or access to information pertaining to the quality of the providers and/or services they are considering, psychological preparation or counseling of each resident as necessary, and making every reasonable effort to accommodate each resident's goals, preferences, and needs regarding receipt of services, location, and setting. Procedures, Section 483.70L. Once notified of a facility's impending closure, if a copy of the facility's plan for the transfer and relocation of the residents was not included with the notice, the state survey agency should immediately request a copy of the facility's closure plan for their review and approval. In addition, the state survey agency should request the facility's admissions records to verify that no new residents have been admitted on or after the date that the notice of closure was provided. A resident who had been temporarily transferred to an acute care setting, is on bed hold, or is on a temporary leave, would not be considered to be a new admission upon return to the facility. However, each of these situations may need to be evaluated on a case-by-case basis in order to determine if the clinical care or social needs of the resident may continue to be met by the facility if transferred back to the facility in closure. If it is determined that the clinical care or social needs of the resident cannot be met by the closing facility and the resident is not transferred back to the closing facility, the same notice requirements specified above apply to the resident and the resident's legal representatives, other responsible parties, and other parties as if the resident was still living in the facility. Interview the administrator and other individuals responsible for managing, overseeing, coordinating, and implementing the plan to evaluate how each component of the plan is being operationalized. Note, the review of certain components, such as an evaluation of the facility's closure plan, policies, and procedures may be conducted off-site by the state survey agency and may include assistance from the state LTC ombudsman as the state survey agency deems suitable and necessary. When conducting an on-site survey prior to the impending closure, tour the facility and interview staff including the medical director, residents, and family. Determine their involvement in and/or knowledge of the facility closure plans and the resident transfer procedures. Determine through observation, interview, and record review, as applicable, that the delivery of resident care and services are continuing to be provided, monitored, and supervised based upon the assessed needs and choices of each resident. If problems are noted, it may be necessary to further investigate and review other quality of care regulations as appropriate. Do not cite quality of care issues under the facility closure regulations. Whether written notices were provided timely and that the notice included the expected date of the resident's transfer to another facility or other setting, and how the facility involved the resident, his or her legal representative or other responsible party, and the resident's primary physician to determine the resident's goals, preferences, and needs in planning for the services, location, and setting to which they will be moved. Note: refer to Section 483.15 for guidance for the post-discharge plan of care for an anticipated discharge, which applies to a resident whom the facility discharges to a private residence or other home and community-based setting, to another nursing home, or to another type of residential facility, such as a board and care home or an intermediate care facility for individuals with intellectual disabilities or mental illness. Note: Section 488.42, 6A1 and 2 transfer of residence or closure of the facility and transfer of residence gives authority to the state for temporary facility closure in emergency situations, if the state survey agency approves a facility's temporary relocation of residents during an emergency with the expectation that the residents will return to the facility. This would not be regarded as a facility closure under these requirements, and the notification requirements would not be applicable. However, if a facility ultimately closes permanently due to an emergency, the administrator is required to provide proper notifications and follow the procedures outlined in this guidance. F847, entering into binding arbitration agreements. Section 483.70M, binding arbitration agreements. If a facility chooses to ask a resident or his or her representative to enter into an agreement for binding arbitration, the facility must comply with all of the requirements in this section. Section 483.70M1, the facility must not require any resident or his or her representative to sign an agreement for binding arbitration as a condition of admission to, or as a requirement to continue to receive care at, the facility, and must explicitly inform the resident or his or her representative of his or her right not to sign the agreement as a condition of admission to, or as a requirement to continue to receive care at the facility. Section 483.70M2, the facility must ensure that the agreement is explained to the resident and his or her representative in a form and manner that he or she understands, including in a language the resident and his or her representative understands. Roman 2, the resident or his or her representative acknowledges that he or she understands the agreement. Section 483.70M3, the agreement must explicitly grant the resident or his or her representative the right to rescind the agreement within 30 calendar days of signing it. Section 483.70M4, the agreement must explicitly state that neither the resident nor his or her representative is required to sign an agreement for binding arbitration as a condition of admission to, or as a requirement to continue to receive care at the facility. Section 483.7, 0M5, the agreement may not contain any language that prohibits or discourages the resident or anyone else from communicating with federal, state, or local officials, including but not limited to federal and state surveyors, other federal or state health department employees, and representative of the office of the state long-term care ombudsman, in accordance with Section 483.10K. Note, the requirements at 483.70M went into effect on September 16, 2019. This guidance is intended for the review of arbitration agreements entered into on or after September 16, 2019. Intent: to ensure that long-term care facilities inform residents or their representatives of the nature and implications of any proposed binding arbitration agreement, to inform their decision on whether or not to enter into such agreements. The requirements at F847 emphasize the residents or their representatives' right to make informed decisions and choices about important aspects of residents' health, safety, and welfare. Facilities may present residents or their representatives the opportunity to utilize a binding arbitration agreement to resolve disputes at any time during a resident's stay, as long as the agreement complies with the regulations at Section 483.7, 0M15. Definitions: arbitration: a private process where disputing parties agree that one or several other individuals can make a decision about the dispute after receiving evidence and hearing arguments. 1. Binding arbitration agreement or agreement. A binding agreement by the parties to submit to arbitration all or certain disputes which have arisen or may arise between them in respect of a defined legal relationship, whether contractual or not. The decision is final, can be enforced by a court, and can only be appealed on very narrow grounds. 2. Pre-dispute binding arbitration agreement, pre-dispute arbitration agreement, or pre-dispute agreement. A binding agreement to resolve a future unknown dispute with an arbitrator prior to any issue or dispute arising. Post-dispute binding arbitration agreement, post-dispute arbitration agreement, or post-dispute agreement. A binding agreement signed after the circumstances of the dispute have occurred to resolve the dispute with an arbitrator. Dispute: a disagreement, controversy, or claim amongst parties where one party claims to have been harmed. Judicial proceedings: any action by a judge, i.e., trials, hearings, petitions, or other matters formally before the court. Guidance section 483.7, 0M12I Roman 235. Over the years, long-term care facilities and residents have used arbitration to resolve many disputes. Parties subject to arbitration give up their right to have some or all claims heard in court. The arbitration epidemic: mandatory arbitration deprives workers and consumers of their rights. https://www.epiorg/publications/the arbitration epidemic/ accessed 1/6/2021. The results of arbitration decisions are typically not disclosed to the public, and arbitrators' decisions are generally final and binding, with little or no opportunity to initiate judicial proceedings that challenge unfavorable decisions. Concerns have been raised about the fairness and transparency related to both the means by which these agreements are created and the fairness of the arbitration processes themselves in the specific context of long-term care facilities. For example, an individual is often admitted to a long-term care facility directly from the hospital after a decline in their health. These individuals are often quite ill and are not in a position to engage in meaningful negotiations over the terms of an arbitration agreement or to coordinate care at another facility. As a result, this is quite often an extremely stressful situation with limited time to review documents before signing them. During this time, long-term care facilities have often required individuals to sign pre-dispute arbitration agreements to obtain health care. These factors, among others, impede individuals' ability to obtain care and simultaneously make it extremely difficult for residents or their representatives to make an informed decision about arbitration. Therefore, asking individuals to commit to binding arbitration agreement in these situations may not represent the best option in terms of advancing the health care of residents. Use of a binding arbitration agreement must be voluntary and must be clearly communicated to the residents or their representatives as optional and not required as a condition of admission or to continue to receive care at the facility. The agreement must be explained so that the resident or his or her representative understands the terms of the agreement. This should include an explanation that the resident may be giving up his or her right to have a dispute decided in a court proceeding, and residents and their representatives must be provided 30 days after signing to fully review and potentially rescind any agreement that was not understood at the time of admission. Pre- and post-dispute arbitration agreements. Binding arbitration agreements may be offered either before pre-dispute or after post-dispute a dispute arises. A pre-dispute binding arbitration agreement is an agreement to resolve an unspecified future dispute. Through arbitration, disputes may vary from a non-life-threatening situation such as a financial disagreement up to and including significant concerns such as abuse, neglect, and or wrongful injury or death of a resident. By entering into a pre-dispute binding arbitration agreement, the parties are not settling an existing dispute but deciding, in advance, the forum in which any future disputes would be resolved. For example, if a resident enters into a pre-dispute arbitration agreement when admitted to a facility, and a few months later, the facility is alleged to have wrongfully caused a type of harm covered by the agreement, such as abuse, the resident cannot seek legal action through the traditional court system. Rather, they must resolve the dispute through the agreed-upon arbitration proceeding. Facilities wishing to utilize pre-dispute binding arbitration agreements will generally offer these arrangements prior to or early in the admission process. Facilities must not require residents or their representatives to enter into a binding pre-dispute arbitration agreement as a condition of being admitted to the facility or as a requirement for continued care. Post-dispute arbitration agreements involve the use of the arbitration process after a dispute occurs which would otherwise be resolved in a court proceeding. In such cases, following an issue which gives rise to a dispute, the facility may propose using an arbitrator to resolve the dispute rather than engage in litigation in court. When the facility wishes to use a post-dispute binding arbitration agreement, existing legal authorities generally provide that the facility must not compel, pressure, or coerce a resident or his or her representative to enter into a binding arbitration agreement, and the regulation provides that the facility must not require arbitration as a condition of receiving continued care at the facility. Requirements for arbitration agreements, transparency in the arbitration process. The requirements at Section 483.70 M2I specify that the arbitration agreement is explained to the resident and his or her representative in a form and manner that he or she understands, including in a language the resident and his or her representative understands. It is important that the arbitration process is transparent. This means that facilities should take every step to meet the resident's needs or special accommodations, e.g. literacy level, font size, format, language, etc. when explaining the arbitration. Agreement. When explaining the agreement, facilities must identify and use the residents or their representatives' preferred communication method, including language, to ensure understanding of the arbitration agreement, the terms and conditions of arbitration. Agreements must be clearly explained to the resident or his or her representative. The requirement at Section 483.70 M2 Roman 2 specifies that the resident or his or her representative acknowledges that he or she understands the agreement. After the arbitration agreement is explained in a manner, inform the resident or their representative understands, the facility must ensure there is evidence that the resident or their representative has acknowledged understanding of the agreement. In some cases, the binding arbitration agreement may specify that the resident or his or her representative acknowledges understanding by signing the document. When a signature is used to acknowledge understanding, additional evidence may be needed to establish that in fact the resident or their representative understood what he or she was signing. It may not be sufficient that the resident or their representative sign the document. It is also important that facilities clarify when a signature is used to acknowledge understanding, when it indicates consent to enter into an agreement, or is used for both purposes. Surveyors should determine how the facility ensures residents or their representatives understood the terms of the binding arbitration agreement and how this understanding is acknowledged. Surveyors must verify through interview and record review that the resident or their representative understood what they were signing. In situations where the resident may have cognitive impairment, surveyors should refer to the medical record to identify the resident's healthcare decision-making capacity at the time the agreement was offered, explained, and entered into. Arbitration agreements embedded within other contracts or agreements. Binding arbitration agreements may not necessarily be a standalone document. Facilities may choose to offer pre-dispute arbitration agreements at the time of admission. Some facilities may embed the arbitration agreement within the admission agreement, contract, or other documents. In these cases, all of the requirements related to arbitration agreements still apply. For example, the facility must explain that the admissions agreement includes a binding arbitration agreement and inform the resident of all of their rights related to this agreement in a form and manner that they understand. Additionally, the facility should clearly distinguish the arbitration agreement from the admission agreement so that residents or their representatives have a clear understanding of each agreement and are able to enter into or decline the arbitration agreement. In other words, residents must be allowed to sign an admissions agreement without consenting to the facility's arbitration agreement. Surveyors should determine how the facility ensures residents or their representatives are made aware of arbitration agreements, which are embedded within another document. Surveyors should also obtain copies of any documents or agreements that include information about arbitration. For example, if a facility's admission agreement has a paragraph referencing arbitration, but also has a separate arbitration agreement, the surveyor will need to examine both documents to ensure compliance. Requirements for arbitration agreements. Language. The requirements at Section 483.70 M1. 35 identify specific terms and conditions which must be explicitly stated in any arbitration agreement between a resident or their representative and a Medicare and / or Medicaid certified facility. Explicitly means clearly and without any vagueness or ambiguity. Thus, these terms and conditions must be disclosed in the agreement in a clear and detailed manner, leaving no room for confusion. For further arbitration agreement language to be included, Refer to F848, specifically. Section 483.7, 0M2 Roman 3, Roman 4. Section 483.70M1, the arbitration agreement, must explicitly inform the resident or his, or her representative of his or her, right not to sign the agreement as a condition of admission to, or as a requirement to continue to receive care at, the facility. This means that the agreement must clearly explain that the resident or their representative has the right to refuse to enter into the arbitration agreement without fear of not being admitted or being transferred or discharged as a result of refusing to enter into an arbitration agreement. Facilities cannot refuse to admit any resident who has, or whose representative has, declined to enter into an arbitration agreement. Additionally, facilities must not discharge any resident for failure to use arbitration to settle a dispute. Note, surveyors should thoroughly investigate the basis for transfer or discharge for any resident who has refused to enter into a binding arbitration agreement and has been, or will be subsequently transferred or discharged. For additional information, refer to the guidance at Section 483.1, 5 CF 622, Transfer and Discharge Requirements. Section 483.7, 0M3. The arbitration agreement must explicitly grant the resident or his or her representative the right to rescind this agreement within 30 calendar days of signing it. This means the agreement must clearly explain that the resident or his or her representative has 30 calendar days to withdraw from or terminate the agreement, should he or she change their mind. This ensures that residents or their representatives have time to reconsider the decision to use arbitration to settle a dispute with the facility. This also allows time for them to seek legal advice if he or she chooses to do so. Facilities should have a process that is also explained to the resident or their representative, which ensures timely communication to the appropriate facility staff of a residence. Resident representatives desire to withdraw from or terminate the arbitration agreement. Otherwise, miscommunications or delays could deny the resident or representative the right to withdraw from the agreement within the 30-day period. Section 483.7, 0M4. The arbitration agreement must explicitly state neither the resident nor his or her representative is required to sign this agreement as a condition of admission to, or as a requirement to continue to receive care at the facility. This means the agreement itself must contain clear language that neither the resident nor the representative are required to enter into the agreement as a condition of admission or to continue to reside at the facility. As stated above at Section 483.70M1, this must be clearly conveyed without any ambiguity, thereby ensuring that no resident or his or her representative will have to choose between signing an arbitration agreement and receiving care at the facility. Section 483.7, 0M5. The arbitration agreement may not contain any language that prohibits or discourages the resident or anyone else from communicating with federal, state, or local officials, including but not limited to federal and state surveyors, other federal or state health department employees, and representative of the Office of the State Long-Term Care Ombudsman, in accordance with Section 483.10K. Residents or their representatives have the right to unrestricted communication with officials from federal agencies, as well as with state and local officials, including representatives from the State Survey Agency, State Health Department, and representatives from the Office of the State Long-Term Care Ombudsman, in addition to prohibition of language in the agreement which discourages such contact or communication This also means that there should be no attempt by facility staff to discourage this communication verbally. Surveyors should verify through interview that the resident or his or her representative were not discouraged in any way from contacting federal, state, or local officials, which includes and is not limited to surveyors and ombudsmen when entering into a binding arbitration agreement. For additional information, refer to the guidance at Section 483.10K. F835, Contact with External Entities. Procedures and Probes Section 483.7, 0M12I Roman 235. Surveyors should verify with the facility whether arbitration agreements are used to resolve disputes. If so, determine compliance with F847 through interview of sampled residents. Resident representatives, resident counsel/family counsel if one exists, long-term care. Ombudsman, facility staff, and record review, which includes reviewing the agreement and other relevant documentation. For facilities that offer arbitration agreements, the following are interview questions that may assist surveyors in their investigation. Surveyors are not required to ask all of the below interview questions, but instead use these example questions as a guide during interviews. Note, these provisions are not intended to supersede or interfere with state laws or other state contract and consumer protection laws, except to the extent any such laws are actually in conflict with this regulation. 84 Fed. Reg. 34,718, 34,721, July 18, 2019. Interviews. A. Resident and/ or his or her representative. For residents who have arbitration agreements, determine the extent to which the arbitration agreement was explained to the resident or representative by asking, what is your understanding of the arbitration process when a dispute arises? Do you understand that you are giving up your right to litigation in a court proceeding? Were you told that the facility could not require you to enter into an arbitration agreement in order to be admitted or in order to remain in the facility? Were you told that you had the right to terminate or withdraw from the agreement within 30 days of signing? If yes, were you told how to do so? Did you feel you were obligated, required, forced, or pressured to sign the binding arbitration agreement? If yes, how so? Have you filed any complaints or grievances with the facility and / or state survey agency about the arbitration agreement? Is there anything you would have liked to have known before signing the arbitration agreement? Was the arbitration agreement explained in a way that you understood? If the arbitration agreement was included within another document, were you told, first, that you had the right to decline the agreement, and second, how to exercise this right, crossing out, etc.? B. Resident counsel/family counsel. For facilities having resident and / or family counsels and that have elected to utilize arbitration agreements, determine if there are general concerns with arbitration agreements. If concerns are identified, surveyors should arrange to meet individually with the resident to discuss their personal / private concerns related to arbitration agreements. For individual interview probes, see resident / representative interview questions above. Ask the following. Has the resident's counsel ever voiced any concerns to the facility about arbitration agreements, such as the way they are explained, pressure, or being forced into signing them, or concerns with the process for withdrawing or terminating an agreement? Do you know if residents feel coerced to sign the arbitration agreement? If yes, how so? Whom from the facility discusses or reviews the binding arbitration agreement with residents or their representatives? C. Facility staff. Interview facility staff responsible for explaining the arbitration agreement to residents or their representatives. Determine how the facility staff ensure the resident or his or her representative understands the agreement by asking, when and under what circumstances do you request that a resident or his or her representative agree to an arbitration agreement? How do you ensure the resident or representative understands the terms of the arbitration agreement? How do you ensure the arbitration agreement is explained in a form and manner that accommodates the resident or his or her representative's needs? How do you make sure the resident understands their rights with regard to the arbitration agreement, such as their right to refuse to enter into it and their right to rescind it within 30 days? What is the process in your facility for allowing residents or their representatives to terminate or withdraw from an arbitration agreement in the first 30 days? Do you know any residentess whom your facility refused admission to or discharged due to refusal to sign a binding arbitration agreement? Have any residents filed a complaint or grievances with the facility regarding the use of an arbitration agreement? How do you determine if the resident's physical condition and his or her cognitive status may be contributing factors in understanding of the binding arbitration agreement, including their ability to make an informed and appropriate decision? D. State long-term care ombudsman if available. Did any resident or his or her representative report that he/she felt forced or pressured into signing the binding arbitration agreements as a condition of admission or as a requirement to continue receiving care at the facility? Do you know any resident whom the facility may have refused admission to or who was discharged due to refusal to sign a binding arbitration agreement? Are you aware of any issues that have been raised regarding binding arbitration agreements? Are you aware of any residents or representatives who sought to rescind a binding arbitration agreement? If yes, how did the facility respond to the rescission request? Record review. Review the resident record as well as the arbitration agreement to ensure the binding arbitration agreement clearly states that the resident or his or her representative is not required to enter into the agreement as a condition of admission to the facility or as a requirement to continue to receive care. The binding arbitration agreement does not include language which prohibits or discourages the resident or representative from communicating with federal, state, or local officials. There is evidence the binding arbitration agreement was explained in a form, manner, and language that the resident or his or her representative understands. There is evidence that the resident had the cognitive ability to understand the terms of the agreement, and evidence the resident acknowledged this understanding. The binding arbitration agreement gives the resident or his or her representative the right to rescind the agreement within 30 calendar days of signing it. For residents who have a representative, there is evidence the representative has the legal authority to sign the binding arbitration agreement. Potential tags for additional consideration. If there are concerns regarding communication with external entities, such as federal and state surveyors, other federal or state health department employees, and representative of the Office of the State Long-Term Care Ombudsman, surveyors should further investigate and review regulatory requirements at Section 483.10K, F835, contact with external entities. If there are concerns regarding admission agreement, surveyors should further investigate and review regulatory requirement at Section 483.15A, F820, admissions policy. If there are concerns regarding the basis for transfer and discharge for any resident who has refused to enter into a binding arbitration agreement and has been, or will be, subsequently transferred or discharged, Surveyors should further investigate and review. Regulatory requirements at Section 483.1, 5C, F822 transfer and discharge. Key elements of noncompliance. To cite deficient practice, at F847, the surveyor's investigation will generally show the facility failed to explain the terms of the agreement to the resident or his or her representative in a form and manner including language that he or she understands, and or inform the resident or his or her representative they are not required to enter into a binding arbitration agreement as a condition of admission or as a condition to continue to receive care at the facility, or inform the resident or representative they have the right to rescind or terminate the agreement within 30 calendar days of signing. The agreement itself contains language that prohibits or discourages the resident or his or her representative from communicating with federal, state, or local officials, including federal and state surveyors, and or other federal or state health department employees, and or representative of the Office of the State Long-Term Care Ombudsman, or fails to contain language which clearly informs the resident or their representative. They are not required to sign the agreement as a condition of admission to, or as a requirement to continue to receive care at the facility. Guidance on identifying noncompliance at F847. In some cases, a resident or his or her representative may not be able to recall the specifics of a conversation, explaining arbitration agreements held during admission or at some point previous to the survey. It is not uncommon for an individual to not remember all the technical details of something they signed in the past, e.g., 6 months ago, if a resident or their representative cannot recall the conversation explaining arbitration agreements or details of the terms of the agreement. This alone may not necessarily indicate noncompliance. However, if several residents do not recall being advised of their rights related to arbitration agreements, the surveyor should conduct further investigation. Conversely, if a resident or his or her representative actively asserts or complains that they remember the admissions conversation and can affirm that the facility staff member did not inform them of their rights related to arbitration, this may indicate noncompliance. In either case, surveyors are expected to verify noncompliance through further investigation with the resident or representative, as well as other residents, staff members, and resident counsel. Guidance on determining severity of noncompliance at F847. When determining the severity of noncompliance at F847, surveyors must always consider what impact the identified noncompliance had on the affected residentess. However, unlike noncompliance at other tags, such as abuse or quality of care, which may result in physical, mental, and or psychosocial outcomes, noncompliance at F847 will almost exclusively have a psychosocial impact or outcome. Surveyors must gather sufficient evidence through interviews, record review, and observation to demonstrate what the psychosocial impact was to the resident. In some cases, the surveyor may have to use the reasonable person concept to determine severity. Refer to the Psychosocial Severity Outcome Guide for further information. The failure of the facility to meet the requirements at F847 is more than minimal harm. Therefore, Severity Level 1 does not apply for this regulatory requirement. Absent evidence of actual harm, noncompliance at F847 would likely be cited at Severity Level 2. No actual harm with potential for more than minimal harm that is not immediate jeopardy. However, if the surveyor identifies that noncompliance at F847 has caused psychosocial harm to the resident per the Psychosocial Severity Outcome Guide. This should be cited. At severity level 3, actual harm that is not immediate jeopardy. In order to cite immediate jeopardy, the surveyor's investigation would have to show that noncompliance resulted in the likelihood for serious psychosocial injury or harm, or caused actual serious psychosocial injury or harm, and required immediate action to prevent further serious psychosocial injury or harm from occurring or recurring. Refer to Appendix Q for further information. Guidance on correcting noncompliance at F847. When noncompliance exists at F847, the plan of correction POC is expected to include the required elements as identified at State Operations Manual, Chapter 7, Section 7317, Acceptable Plan of Correction. These include address how corrective action will be accomplished for those residents found to have been affected by the deficient practice. Address how the facility will identify other residents having the potential to be affected by the same deficient practice. Address what measures will be put into place or systemic changes made to ensure that the deficient practice will not recur. Indicate how the facility plans to monitor its performance to make sure that solutions are sustained, and include dates when corrective action will be completed. When the surveyor's investigation shows systemic noncompliance, indicating a complete disregard or unawareness of the requirements, such as the standard use of arbitration agreements containing language which violates the requirements at F847, evidence that the facility has made no attempt to explain arbitration agreements or evidence of overt attempts to conceal arbitration agreements within other documents. In addition to the requirements for POCs listed above, CMS has the following expectations with regard to the accepted POC. The POC must ensure that any new or revised arbitration agreements in use in the facility complies with the requirements at F847. Surveyors must review the revised agreements and confirm that they comply with F847. If a resident or their representative has signed a non-compliant agreement, the facility must ensure that the resident or their representative is promptly notified that the agreement does not comply with Section 483.70M, and it must promptly offer the resident or their representative a compliant agreement. The facility must explain the terms of the new agreement to the residents or their representatives, and do so in terms the residents or their representatives can understand, and all other requirements at F847 are met. 1. Adapted from American Bar Association. Dispute Resolution Processes, Arbitration, American Bar Org. Accessed 1/6/2021. 2. Adapted from American Bar Association. Dispute Resolution Processes, Arbitration, American Bar Org. Accessed 1/6/2021. F848, Arbitrator/Venue Selection and Retention of Agreements. Section 483.70M, Binding Arbitration Agreements. If a facility chooses to ask a resident or his or her representative to enter into an agreement for binding arbitration, the facility must comply with all of the requirements in this section. Section 483.70M2, the facility must ensure that Roman 3, the agreement provides for the selection of a neutral arbitrator agreed upon by both parties, and Roman 4, the agreement provides for the selection of a venue that is convenient to both parties. Section 483.70M6, when the facility and a resident resolve a dispute through arbitration. A copy of the signed agreement for binding arbitration and the arbitrator's final decision must be retained by the facility for 5 years after the resolution of that dispute. On and be available for inspection upon request by CMS or its designee. Note, the requirements at 483.70M went into effect on September 16, 2019. This guidance is intended for the review of arbitration agreements entered into on or after September 16, 2019. Intent: to provide a neutral and fair arbitration process by ensuring both the resident or his or her representative and the facility agree on the selection of a neutral arbitrator and that the venue is convenient to both parties. In addition, the requirement to retain a copy of the signed agreement for binding arbitration and the arbitrator's final decision enables CMS to ensure that CMS can fully evaluate quality of care complaints that are addressed in arbitration and assess the overall impact of these agreements on the safety and quality of care provided in long-term care facilities. Definitions: arbitrator, a third party who resolves a dispute between others by arbitration and pursuant to an arbitration agreement. Arbitrators are decision makers with procedures set by the arbitration agreement and state law, except they may not be required to follow federal or state rules of evidence, and their decisions may not be reviewable by a court. Absent extraordinary circumstances. Convenient venue, a location in which to carry out arbitration proceedings which should be agreed upon and suitable to both parties. Neutral arbitrator, an impartial or unbiased third-party decision-maker contracted with and agreed to by both parties to resolve their dispute. Guidance: the requirement at Section 483.70 M2 Roman 3 states, the facility must ensure that the agreement provides for the selection of a neutral arbitrator agreed upon by both parties. Facilities wishing to utilize binding arbitration agreements should make reasonable efforts to ensure that any arbitration agreement entered into with a resident or his or her representative provides for the selection of an arbitrator who is impartial, unbiased, and without the appearance of a conflict of interest. This ensures the integrity of the arbitration process and also ensures that residents who choose this alternative dispute resolution are treated with the same fairness they would have if they chose to litigate. Facilities may put forward suggestions for the use of specific arbitrators for residents or their representatives to select. The resident or his or her representative is not obligated to use the arbitrator, either an arbitration services company or an individual arbitrator suggested by the facility, and may suggest an alternative arbitrator of their choosing. Facilities are expected to make a reasonable attempt to come to agreement with the resident or resident's representative on the selection of a neutral arbitrator and provide a fair process for selecting an arbitrator or arbitration services company. To ensure a neutral arbitrator is selected, the facility should avoid even the appearance of bias, partiality, or a conflict of interest, and should promptly disclose to the resident or his or her representative the extent of any relationship which exists with an arbitrator or arbitration services company, including how often the facility has contracted with the arbitrator or arbitration service, and when the arbitrator or arbitration service has ruled for or against the facility. The requirement at Section 483.70 M2 Roman 4 states, the facility must ensure the agreement provides for the selection of a venue that is convenient to both parties. The binding arbitration agreement must allow for the selection of a venue that is suitable in meeting the needs of both the resident or his or her representative and the facility. The venue should be agreed upon by both parties. The venue is the geographical location of the arbitration proceeding that may be chosen in part on the basis of convenience. Convenience for the resident or resident's representative may be determined by his or her needs in terms of ability to get to the venue. The requirements at Section 483.70 M6 state that when the facility and a resident resolve a dispute through arbitration, a copy of the signed agreement for binding arbitration, and the arbitrator's final decision must be retained by the facility for 5 years after the resolution of that dispute on, and be available for inspection upon request by CMS or its designee. When a dispute is resolved through arbitration, facilities are accountable and responsible for retaining a copy of the signed binding arbitration agreement and final decision for a period of 5 years following resolution of the arbitrated dispute. These records must be made available for review to surveyors upon request. Note, it is important for surveyors to focus on the record retention requirement, not the content of the arbitration agreement or final decision S, in determining compliance with this requirement. Procedures and Probes Section 483.70 M2 Roman 3 and Roman 4. Surveyors should verify with the facility whether arbitration agreements are used to resolve disputes. If so, determine compliance with F848 through interview of sampled residents, resident representatives, resident counsel/family counsel if one exists, long-term care, ombudsman, facility staff, and record review, which includes reviewing the agreement and other relevant documentation. For facilities that offer arbitration agreements, the following are interview questions that may assist surveyors in their investigation. Surveyors are not required to ask all of the below interview questions, but instead use these example questions as a guide during interviews. Note, these provisions are not intended to supersede or interfere with state laws or other state contract and consumer protection laws, except to the extent any such laws are actually in conflict with this regulation. 84 Fed. Reg. 34,718, 34,721, July 18, 2019. Interviews. A. Resident or representative S. Interview the resident or their representative to determine the process for selecting a neutral arbitrator and convenient venue. Ask, how were you included in selecting the arbitrator? Were you given a choice in arbitrator? Were you given an opportunity to suggest an arbitrator? Do you agree with the arbitrator that was selected? Was more than one arbitrator suggested? Was a list of arbitrators to select from provided, or alternatively, were you made aware of how to search for arbitration companies? What did the facility tell you about the arbitrator or arbitration services company? Are you aware of any relationship or association between the facility and the arbitrator? How were you included in selecting the venue? Were you given a choice in venue? Was the agreed upon venue convenient to you and or your representative? When were the arbitrator and venue selected? Under what circumstances? Did the facility reject any of your preferred arbitrators or venues? Why? Are you aware whether or not the facility used the same arbitrator or company in the past? B. Resident counsel/family counsel. For facilities having resident and or family counsels and have elected to utilize arbitration agreements, determine if there are general concerns with arbitration agreements. If concerns are identified, surveyors should arrange to meet individually with the resident to discuss their personal/private concerns related to arbitration agreements. For individual interview probes, see resident/representative. Interview questions above. Ask the following. Are you aware of any concerns about the selection of a neutral arbitrator and or the selection of a convenient venue? Remind residents not to share personal, private. Information in the group setting. C. Facility staff. Interview the facility staff responsible for facilitating the selection of a neutral arbitrator and convenient venue. Ask, how do you ensure that the resident or his or her representative has an equal role in selecting a neutral arbitrator? What is your process for selecting a neutral arbitrator? How do you ensure that the resident or his or her representative has an equal role in selecting a convenient venue? What is your process for selecting a convenient venue? When a resident or his or her representative do not agree with the arbitrator and or venue, what are the next steps? How does the agreement provide for the selection of the arbitrator is agreed upon by both parties? What is the facility's policy on retention of the signed binding arbitration agreements and the final dispute documentation? When and under what circumstances do you approach residents or their representatives about selecting an arbitrator or venue? Are there any active complaints or grievances regarding the selection of an arbitrator or venue? How are you addressing these concerns? What information do you provide residents or their representatives regarding specific arbitrators or arbitration services companies, i.e., regarding parent corporation/owners using specific arbitration company? Have you used more than one arbitrator/arbitration services company in the past few years? How many times have you contracted with the same company? D. State long-term care ombudsman if available. Interview the representative of the state long-term care ombudsman who serves resident of the facility. Ask, did any resident or his or her representative ask your assistance to select an arbitrator or venue? Did any resident or his or her representative complain to you that he/she was forced or pressured to select a particular arbitrator/arbitration company or venue? Did any resident or his or her representative report that an arbitrator and/or venue was pre-selected, i.e., the resident or his or her representative did not have an opportunity to agree to an arbitrator and/or venue? Did any resident or his or her representative complain the venue was inconvenient to them? Record review. Review the binding arbitration agreement, any other pertinent information relevant to the selection of the arbitrator and venue, as well as the arbitrators. Final decision after resolution of a dispute, if applicable, to identify the following. Is there evidence that the resident or his or her representative were provided with the opportunity to select a neutral arbitrator? Is there evidence that the resident or his or her representative were provided with the opportunity to select a convenient venue? Is there evidence the facility retained a copy of the signed agreement for binding arbitration and the arbitrator's final decision after the resolution of a dispute through arbitration for 5 years? Key elements of noncompliance. To cite deficient practice at F848, the surveyor's investigation will generally show that the facility failed to do any one or more of the following. Ensure that the arbitration agreement specifically provides for the selection of a neutral arbitrator, or ensure that the arbitration agreement specifically provides for the selection of a venue that is convenient, or for disputes resolved by arbitration, the facility failed to retain a copy of the signed agreement for binding arbitration and the arbitrator's final decision for disputes resolved by arbitration after the facility and a resident or their representative resolve a dispute through arbitration for 5 years, or refuse to make the signed agreement or final decision available for inspections upon request by CMS or its designee. Guidance on identifying noncompliance at F848. In some cases, a resident or his or her representative may not be able to recall all the specifics about the selection of a neutral arbitrator or convenient venue. If a resident or their representative cannot recall the details of the selection of a neutral arbitrator or a convenient venue, this alone may not necessarily indicate non-compliance. However, if several residents do not recall the process of selecting a neutral arbitrator or a convenient venue, the surveyor should conduct further investigation. Conversely, if a resident or his or her representative actively asserts or complains that there is no process for the selection of a neutral arbitrator or a convenient venue to both parties, this likely constitutes noncompliance. In either case, surveyors are expected to verify noncompliance through further investigation with the resident or representative, as well as other residents, staff members, and resident counsel. Guidance on determining severity of noncompliance at F848. When determining the severity of noncompliance at F848, surveyors must always consider what impact the identified noncompliance had on the affected residentess. However, unlike noncompliance at other tags, such as abuse or quality of care, which may result in physical, mental, and/or psychosocial outcomes, noncompliance at F848 will almost exclusively have a psychosocial impact or outcome. Surveyors must gather sufficient evidence through interviews, record review, and observation to demonstrate what the psychosocial impact was to the resident. In some cases, the surveyor may have to use the reasonable person concept to determine severity. Refer to the Psychosocial Severity Outcome Guide for further information. If the surveyor identifies noncompliance at F848 for the failure to retain signed arbitration agreements or the arbitrator's final decision for residents that have resolved a dispute through arbitration for 5 years, Severity Level 1 may be the appropriate severity level for this regulatory requirement. In other cases, noncompliance at the other requirements at F848 failure for the agreement to provide for the selection of a neutral arbitrator or convenient location would likely be cited at Severity Level 2, no actual harm with potential for more than minimal harm that is not immediate jeopardy. If the surveyor identifies that noncompliance at F848 has caused psychosocial harm to the resident per the Psychosocial Severity Outcome Guide, this should be cited at Severity Level 3, actual harm that is not immediate jeopardy. In order to cite immediate jeopardy, the surveyor's investigation would have to show that noncompliance resulted in the likelihood for serious psychosocial injury or harm, or caused actual serious psychosocial injury or harm, and required immediate action to prevent further serious psychosocial injury or harm from occurring or recurring. Refer to State Operations Manual SOM Appendix Q for further information. Guidance on correcting noncompliance at F848. When noncompliance exists at F848, the plan of correction POC is expected to include the required elements as identified in the SOM, Chapter 7 at 7317, Acceptable Plan of Correction. These include: address how corrective action will be accomplished for those residents found to have been affected by the deficient practice. Address how the facility will identify other residents having the potential to be affected by the same deficient practice. Address what measures will be put into place or systemic changes made to ensure that the deficient practice will not recur. Indicate how the facility plans to monitor its performance to make sure that solutions are sustained, and include dates when corrective action will be completed. When the surveyor's investigation shows systemic noncompliance with F848, indicating a complete disregard or unawareness of the requirements, such as Agreements, which make no provision for the selection of a neutral arbitrator. Convenient venue. CMS has the following expectations in addition to the requirements for POCs listed above with regard to the accepted POC. The POC must ensure that all arbitration agreements allow for the selection of a neutral arbitrator and convenient venue, and there must be a process to ensure records are retained for 5 years. Tag F849. Section 483.7, 0N Hospice Services. Section 483.70N1. A long-term care LTC facility may do either of the following. I arrange for the provision of hospice services through an agreement with one or more Medicare-certified hospices. Roman 2. Not arrange for the provision of hospice services at the facility through an agreement with a Medicare-certified hospice and assist the resident in transferring to a facility that will arrange for the provision of hospice services when a resident requests a transfer. Section 483.70N2. If hospice care is furnished in an LTC facility through an agreement, as specified in paragraph 01I of this section with a hospice, the LTC facility must meet the following requirements. I ensure that the hospice services meet professional standards and principles that apply to individuals providing services in the facility and to the timeliness of the services. Roman 2. Have a written agreement with the hospice that is signed by an authorized representative of the hospice and an authorized representative of the LTC facility before hospice care is furnished to any resident. The written agreement must set out at least the following. A. The services the hospice will provide. B. The hospice's responsibilities for determining the appropriate hospice plan of care as specified in Section 418.112D of this chapter. C. The services the LTC facility will continue to provide based on each resident's plan of care. D. A communication process, including how the communication will be documented between the LTC facility and the hospice provider to ensure that the needs of the resident are addressed and met 24 hours per day. E. A provision that the LTC facility immediately notifies the hospice about the following. 1. A significant change in the resident's physical, mental, social, or emotional status. 2. Clinical complications that suggest a need to alter the plan of care. 3. A need to transfer the resident from the facility for any condition. 4. The resident's death. F. A provision stating that the hospice assumes responsibility for determining the appropriate course of hospice care, including the determination to change the level of services provided. G. An agreement that it is the LTC facility's responsibility to furnish 24-hour room and board care, meet the resident's personal care and nursing needs in coordination with the hospice representative, and ensure that the level of care provided is appropriately based on the individual resident's needs. H. A delineation of the hospice's responsibilities, including but not limited to providing medical direction and management of the patient, nursing, counseling including spiritual, dietary and bereavement, social work, providing medical supplies, durable medical equipment and drugs necessary for the palliation of pain and symptoms associated with the terminal illness and related conditions, and all other hospice services that are necessary for the care of the resident's terminal illness and related conditions. I. A provision that, when the LTC facility personnel are responsible for the administration of prescribed therapies, including those therapies determined appropriate by the hospice and delineated in the hospice plan of care, the LTC facility personnel may administer the therapies where permitted by state law and as specified by the LTC facility. J. A provision stating that the LTC facility must report all alleged violations involving mistreatment, neglect, or verbal, mental, sexual, and physical abuse, including injuries of unknown source, and misappropriation of patient property by hospice personnel to the hospice administrator immediately when the LTC facility becomes aware of the alleged violation. K. A delineation of the responsibilities of the hospice and the LTC facility to provide bereavement services to LTC facility staff. Section 483.7, 0 and 3, each LTC facility arranging for the provision of hospice care under a written agreement must designate a member of the facility's interdisciplinary team, who is responsible for working with hospice representatives to coordinate care to the resident provided by the LTC facility staff and hospice staff. The interdisciplinary team member must have a clinical background, function within their state scope of practice act, and have the ability to assess the resident or have access to someone that has the skills and capabilities to assess the resident. The designated interdisciplinary team member is responsible for the following: I. Collaborating with hospice representatives and coordinating LTC facility staff participation in the hospice care planning process for those residents receiving these services. Roman 2. Communicating with hospice representatives and other healthcare providers, participating in the provision of care for the terminal illness, related conditions, and other conditions to ensure quality of care for the patient and family. Roman 3. Ensuring that the LTC facility communicates with the hospice medical director, the patient's attending physician, and other practitioners, participating in the provision of care to the patient as needed to coordinate the hospice care with the medical care provided by other physicians. Roman 4. Obtaining the following information from the hospice: A. The most recent hospice plan of care specific to each patient. B. Hospice election form. C. Physician certification and recertification of the terminal illness specific to each patient. D. Names and contact information for hospice personnel involved in hospice care of each patient. E. Instructions on how to access the hospice's 24-hour on-call system. F. Hospice medication information specific to each patient. G. Hospice physician and attending physician if any orders specific to each patient. V. Ensuring that the LTC facility staff provides orientation in the policies and procedures of the facility, including patient rights, appropriate forms, and record-keeping requirements to hospice staff furnishing care to LTC residents. Section 483.7, 0 and 4, each LTC facility providing hospice care under a written agreement must ensure that each resident's written plan of care includes both the most recent hospice plan of care and a description of the services furnished by the LTC facility to attain or maintain the resident's highest practicable physical, mental, and psychosocial well-being, as required at Section 483.24. Definitions, Section 483.70n. Hospice care means a comprehensive set of services described in Section 1861dd1 of the Social Security Act, identified and coordinated by an interdisciplinary group (IGE) to provide for the physical, psychosocial, spiritual, and emotional needs of a terminally ill patient and or family members as delineated in a specific patient plan of care. 42 CFR. Section 418.3 note. These services are provided by a Medicare-certified hospice. Hospice attending physician. This clarifies that a doctor of medicine, osteopathy, or nurse practitioner, if meeting the listed requirements, may function as the attending physician in a hospice, The hospice regulations do not provide for a physician assistant to function as the hospice attending physician. Section 418.3 definitions. For the purposes of this part, attending physician means a one-eye doctor of medicine or osteopathy, legally authorized to practice medicine and surgery by the state in which he or she performs that function or action, or Roman II nurse practitioner, who meets the training, education, and experience requirements as described in Section 410.75b of this chapter. 2 is identified by the individual at the time he or she elects to receive hospice care as having the most significant role in the determination and delivery of the individual's medical care. In a nursing home, a physician's assistant may not act as the hospice attending physician. However, the resident's attending physician at the nursing home may delegate tasks to a physician's assistant per F835 Section 483.30E1. Palliative care means patient and family-centered care that optimizes quality of life. By anticipating, preventing, and treating suffering, palliative care throughout the continuum of illness involves addressing physical, intellectual, emotional, social, and spiritual needs, and to facilitate patient autonomy, access to information, and choice. Section 418.3. Terminally ill means that the individual has a medical prognosis that his or her life expectancy is 6 months or less if the illness runs its normal course. Section 418.3. Bereavement counseling means emotional, psychosocial, and spiritual support and services provided before and after the death of the patient to assist with issues related to grief, loss, and adjustment. Section 418.3. Guidance Section 483.70N. Provision of hospice services in a nursing home. As described in Section 483.70N1I, Roman II, there is no requirement that a nursing home allow a hospice to provide hospice care and services in the facility. If a nursing home has made arrangements with one or more hospices to provide services in the nursing home, there must be a written agreement describing the responsibilities between each hospice and the nursing home prior to the hospice initiating care for a resident who has elected the hospice benefit. The written agreement applies to the provision of all hospice services. For any nursing home, resident receiving services from the specific hospice and does not need to be rewritten for each resident. If the nursing home has a written agreement with one or more hospice providers, it must, in accordance with F851 Section 483.10G16, inform each resident before or at the time of admission and periodically during the resident's stay of hospice, among other services available in the nursing home. If the nursing home has an agreement with more than one hospice, this information must be provided to the resident/designated representative in order to allow choice of the hospice provider he/she prefers. If a resident chooses a hospice that does not have an agreement with the nursing home may establish a written agreement with the hospice and allow the hospice provider to provide hospice services in the nursing home, or the nursing home must assist the resident when the resident requests in transferring to a nursing home of his or her choice that has an agreement or will arrange for the provision of hospice services with a hospice, or in relocating to a non-nursing home setting, e.g. inpatient hospice unit, private home, or residential/assisted living facility that uses the hospice of his or her choice, or the resident may choose not to elect the hospice benefit and continue to reside in the nursing home with the attending physician/practitioner of their choice and receive nursing home care and services. If the nursing home or the hospice terminates the written agreement, the nursing home must provide assistance to affected residents in contacting or selecting another hospice provideress with which the nursing home has or will enter into a written agreement, or, when the resident requests, assist the resident in transferring to a nursing home of his or her choice that has an agreement or will enter into an agreement for the provision of hospice services, or in relocating to a non-nursing home setting, e.g., inpatient hospice unit, private home, or residential/assisted living facility that uses the hospice of his or her choice, or the resident may choose to revoke the hospice benefit and continue to reside in the nursing home with the attending physician/practitioner of their choice and receive nursing home care and services. Note, when a resident/designated representative requests and/or initiates a discharge to another facility or location, the nursing home is not required to provide a notice of discharge and/or transfer, as it is not a nursing home-initiated transfer/discharge. This applies in the situation in which there is no written agreement for hospice services, and/or the resident chooses a hospice with which the nursing home does not have a written agreement, and the nursing home chooses not to establish such an agreement. Nursing home ensures professional standards and timeliness of services. As described in Section 483.70N2I, the nursing home must ensure that services provided by the hospice, including the individuals providing the services, meet professional standards and principles, that the services and care meet the assessed needs of each resident, and that the hospice is certified for participation in the Medicare program. Refer to F835 and F858. The nursing home and hospice must assure that all physicians/practitioners meet state licensure requirements and are working within their scope of practice and professional state licensure requirements. The nursing home staff must monitor the delivery of care in order to assure that the hospice provides services to the resident in a way that meets his or her needs in a timely manner, including observation of interactions and care provided by the hospice staff sufficient to assure that the hospice services meet the professional standards of care. Interviews with the resident/designated representative regarding hospice care and services, and review of the resident's record for pertinent documentation regarding the delivery of hospice care. For example, if a resident has an increase in pain that is not being managed by the current interventions, or if current interventions may be causing adverse consequences that are distressing to the resident, the requirement that the nursing home ensure the provision of timely hospice services would include notifying the hospice of the resident's change in condition so that the hospice, in consultation with the nursing home and the residents, attending physician/practitioner, can reassess the resident and, with input from the resident/designated representative, change the plan of care as indicated to assure the resident receives the treatment necessary to achieve his or her optimal comfort level. Signed written agreement with hospice prior to provision of care. As described in Section 483.70N2 Roman 2A, the written agreement must be signed by authorized representatives of the hospice and the nursing home prior to the provision of hospice services. The hospice retains primary responsibility for the provision of hospice care and services based upon the resident's assessments and choices, according to hospice regulations at Section 418.100C2, nursing services, physician services, and drugs and biologicals as specified in Section 418.106 must be made routinely available on a 24-hour basis, 7 days a week, Other covered services must be available on a 24-hour basis when reasonable and necessary to meet the needs of the patient and family. Other covered services include counseling including spiritual, dietary and bereavement, social work, hospice aid, volunteer and homemaker services, physical therapy, occupational therapy and speech, language pathology services, short-term inpatient care, drugs, biologicals and medical, appliances related to the palliation and management of the terminal illness, and related conditions. Section 418.112C6. Hospice Plan of Care. As described in Section 483.70 N2 Roman 2b, when a hospice patient is a resident of a nursing home, the hospice must establish the hospice plan of care in coordination with the nursing home, the resident's nursing home attending physician/practitioner, and to the extent possible, the resident/designated representative. In order to provide continuity of care, the hospice and the nursing home must collaborate in the development of a coordinated plan of care for each resident receiving hospice services. The structure of the plan of care is established by the nursing home and the hospice. The coordinated plan of care must identify the provider responsible for performing each or any specific services/functions that have been agreed upon. The plan of care may be divided into two portions, one maintained by the nursing home and the other maintained by the hospice. The nursing home and the hospice must be aware of the location and content of the coordinated plan of care, which includes the nursing home portion and the hospice portion, and the plan must be current and internally consistent in order to assure that the needs of the resident for both hospice care and nursing home care are met at all times. The nursing home must designate a member of the nursing home's interdisciplinary team who is responsible for working with hospice to coordinate care for the resident. See Section 483.70 N3I below. In addition, different nursing home staff who are knowledgeable regarding the resident's care may also work with hospice staff in the development of the plan of care. The hospice coordinator must provide ongoing coordination and collaboration with the nursing home coordinator, the resident's attending physician/practitioner, and the resident/designated representative regarding changes to the resident's plans of care. Based on the shared communication between the hospice and the nursing home, the coordinated plans of care should reflect the identification of diagnoses, a common problem list, palliative interventions, palliative goals/objectives, responsible discipline S, responsible provider S, and resident/designated representative choices regarding care and goals. Nursing home responsibilities. As described in Section 483.70 N2 Roman 2c, the nursing home retains primary responsibility for implementing those aspects of care that are not related to the duties of the hospice. The nursing home services must be consistent with the plan of care developed in coordination with the hospice, and the nursing home must offer the same services to its residents who have elected the hospice benefit as it furnishes to its residents who have not elected the hospice benefit. Therefore, the hospice patient residing in a nursing home should not experience any lack of services or personal care because of his or her status as a hospice patient. This includes what would normally be provided to a resident in the nursing home, including but not limited to the following: conducting the comprehensive assessments, which includes the Resident Assessment Instrument RI, providing personal care, activities, medication administration, required physician visits monthly, medication regimen review, support for activities of daily living, social services as appropriate, nutritional support and services, and monitoring the condition of the resident. The nursing home must maintain an environment in which there are no inappropriate signs posted in residence rooms or in staff work areas visible by other residents and or visitors that include confidential clinical or personal information, such as information about hospice services. Refer to F835, Dignity. Communication process between nursing home and hospice. As described in Section 483.7, 0N2 Roman 2D, the written agreement must specify a process for communicating necessary information regarding the resident's care between the nursing home and the hospice 24 hours a day, 7 days a week, including how these communications will be documented. Both the hospice and the nursing home may document physician orders in the residence nursing home record. Orders are to be dated and signed in accordance with federal requirements. Refer to F811, Physician Orders, and any applicable state laws. There is no federal regulation that prohibits nursing home staff from taking orders for care from the hospice physician. Any changes to orders initiated by the hospice should be communicated to the resident's attending physician/practitioner in a timely manner. The nursing home must communicate with the hospice regarding orders provided by the resident's attending physician/practitioner in the nursing home if he/she is not the resident's designated physician on the hospice team. Prior to plan of care or order changes, the hospice physician and the resident's attending physician/practitioner may need to collaborate to address an emergent change in the resident's condition and to assure the resident's needs are met. If there is a conflict between orders given by hospice and the resident's attending physician/practitioner, there must be communication between the nursing home and the hospice regarding the issue. This communication should include the nursing home medical director and the hospice medical director, as well as other pertinent staff as needed. Notifying hospice regarding clinical changes. As described in Section 483.7, 0N2 Roman 2E, the written agreement must include a provision that the nursing home will immediately contact and communicate with the hospice staff regarding any significant changes in the resident's status, clinical complications, or emergent situations. Situations include, but are not limited to, changes in cognition or sudden unexpected decline in condition, a fall with a suspected fracture or adverse consequences related to a medication or therapy, or other situations requiring a revision to the plan of care. The immediate notification to hospice does not change the requirement that a nursing home must also immediately notify the resident's attending physician/practitioner. Prior to plan of care or order changes, the hospice and the resident's attending physician/practitioner may need to collaborate to address this change and to assure that the resident's immediate and ongoing treatment and care needs are met in accordance with the resident's decisions and advance directives regarding end-of-life care are met, including situations which could require a potential transfer to an acute care setting. This decision-making must be consistent with the resident's wishes and most current version of advance directive, if any. Refer to F878 if there is a conflict between the nursing home and the hospice regarding the course of hospice care or level of service. There must be communication between the nursing home and the hospice regarding the issue. This communication should include the nursing home medical director and the hospice medical director, as well as other pertinent staff, as needed. Hospice determines level of hospice services. As described in Section 483.7, 0N2 Roman 2F, the written agreement must state that the hospice assumes responsibility for professional management of the resident's hospice services. provided in accordance with the hospice plan of care and the hospice conditions of participation, and make any arrangements necessary for hospice-related inpatient care in a participating Medicare/Medicaid facility section 418.112b. The agreement must also include language that the hospice assumes the responsibility for determining the level of hospice services. Any substantive changes in the level of hospice services must be developed by the hospice, and these changes must be reflected in the coordinated plan of care. These changes should be made in collaboration with the resident/designated representative, the resident's attending physician/practitioner, and nursing home staff. Nursing home responsibilities for personal care and nursing needs in coordination with hospice. As described in Section 483.70 Roman 2G, the provisions of the written agreement must delineate how the care and needs will be provided based upon the resident's identified needs. It is the nursing home's responsibility to continue to furnish 24-hour room and board care, meeting the resident's personal care and nursing needs. Services provided must be consistent with the plan of care developed in coordination with the hospice. Interdisciplinary group IGE. Delineation of hospice responsibilities. As described in Section 483.70 Roman 2H, to comply with this requirement, the written agreement must contain a clear statement that the hospice assumes responsibility for determining the appropriate course of hospice care to be provided and delineate the services that the hospice is required to provide to the resident not already covered by the nursing home through the provision of room and board and services to meet the resident's personal care and nursing needs as required by Section 483.70 Roman 2G. When the resident elects the hospice benefit, the resident may choose to specify his or her nursing home attending physician/practitioner as the hospice attending physician. If the resident does not choose his or her nursing home attending physician, he/she may select another physician/practitioner as the hospice attending physician. The hospice IDG, in collaboration with the resident's nursing home attending physician/practitioner, is responsible for the palliation and management of specified aspects of care based on the agreement. The agreement identifies the process for developing the plan of care in collaboration with the resident's attending physician/practitioner and includes the process to be followed to reconcile disagreements between the resident's attending physician/practitioner and hospice physician. Note, the nursing home regulations at F810 physician supervision requires that the facility must ensure that another physician supervises the medical care of residents when their attending physician is unavailable, according to the Hospice Co-PTCS at Section 418.64A and A3 Standard. Physician services, the hospice medical director, physician employees, and contracted physicianess of the hospice, in conjunction with the patient's attending physician, are responsible for the palliation and management of the terminal illness and conditions related to the terminal illness. 3. If the attending physician is unavailable, the medical director, contracted physician, and/or hospice physician employee is responsible for meeting the medical needs of the patient. The written agreement must identify how the nursing home will obtain information regarding the provision of medical care, including medication information, from the hospice, and should include the identification of hospice non-physician practitioners who, according to state law, may provide orders for medical care of the resident. Nursing home responsibilities for administration of prescribed therapies. As described in Section 483.70 0N2 Roman 2I. The written agreement must include the provision that the LTC facility personnel may administer therapies where permitted by state law, and as specified by the LTC facility, as noted in the Coordinated Plan of Care. Report to hospice any alleged violations of mistreatment, neglect, verbal, mental, sexual, and physical abuse, including injuries of unknown source and / or misappropriation of property by hospice personnel. As described in Section 483.7, 0N2 Roman 2J, the nursing home must follow all of the requirements within Section 483.12 A, B, and C, free from abuse, F600 to 610 for the prevention, identification, protection, reporting, and investigation of allegations of abuse, neglect, verbal, mental, sexual abuse, mistreatment, and injuries of unknown source. This also includes prohibiting taking and / or posting photos or recordings that are demeaning and or humiliating to a nursing home resident, or the use of an authorized photo or recording in a demeaning / humiliating manner. The privacy and confidentiality of the resident's care and records must be maintained. Refer to F835 privacy and confidentiality. The nursing home must also notify the hospice administrator of any such allegations involving hospice employees and contractors and anyone else providing services on behalf of the hospice and the outcome of its investigation. Note, the hospice must follow the requirements as indicated in the federal regulations. At Section 418.5, 2B4I Roman 4, for reporting, investigating, and taking appropriate corrective actions, responsibilities for bereavement services for nursing home staff. As described in Section 483.7, 0N2 Roman 2K, the death of the resident may have a direct impact on identified nursing home staff. The written agreement should specify when the nursing home should provide information to the hospice regarding nursing home staff that may benefit from bereavement services. The written agreement between the hospice and the nursing home should specify how bereavement services will be coordinated and operationalized by the hospice provider for nursing home staff. The written agreement must include a description of the nursing home's role in providing such services. These services should be individualized based on the resident involved and the staff involvement in their care. In the case of several hospices offering services in a nursing home, each hospice's written agreement must include the provision regarding bereavement services for staff, as noted above. Note, according to the Hospice Co-PTCS, at Section 418.6, 4D counseling services must include, but are not limited to, the following. 1. Bereavement counseling. The hospice must, Roman 2, make bereavement services available to the family and other individuals in the bereavement plan of care up to 1 year following the death of the patient. Bereavement counseling also extends to residents of a SNF/NF or ICF/MR when appropriate and identified in the bereavement plan of care. Nursing home designee's responsibilities. As described in Section 483.70 IV, the nursing home must identify and designate, in writing, an employee of the nursing home to assume the responsibilities for collaborating and coordinating activities between the nursing home and the hospice. The nursing home employee must have a clinical background, function within their state scope of practice, act and have the ability to assess the resident or have access to someone that has the skills and capabilities to assess the resident. The designated nursing home coordinator should be familiar with hospice philosophy and practices. The nursing home should provide the name of the designated nursing home staff member to the Resident/representative for ongoing communication regarding care or concerns. If the designated employee is not available, the nursing home may delegate this function to another nursing home employee who meets the requirements identified above. It should be noted that in nursing homes contracting with more than one hospice, the nursing home may designate more than one/different employees to serve as coordinator with the respective hospices, due to the complex clinical needs of a resident who is in the terminal stages of life. The interdisciplinary team member must have the ability to assess the resident or have access to someone who has the ability to assess the resident. The communication process established should include a system for the designated interdisciplinary team member to obtain the information as identified at Section 483.70 Roman 4 AG. The resident's nursing home record must have evidence of this information. The designated employee is responsible for assuring that orientation is provided to hospice staff. This orientation is meant to address the overall facility environment, including policies, rights, record-keeping, and forms requirements. It is important for the nursing home to document and have available information regarding hospice staff orientation. Note, refer to Section 418.112F. In addition to the orientation that nursing homes must provide to hospice staff, hospices must provide orientation to nursing home staff providing care for hospice patients. The orientation requirements, while separate regulations for both the nursing home and hospice, should be a collaborative effort to assure that the hospice employees provide services and care effectively in the nursing home, and that the hospice ensures that the nursing home staff understands the basic philosophy and principles of hospice care. If a nursing home has written agreements with multiple hospice providers, the nursing home should collaborate with each hospice to assure that the nursing home staff are familiar with specific policies and procedures for each individual hospice. It may not be necessary for each hospice to provide information to nursing home staff regarding the hospice philosophy and principles of care if the nursing home staff has received this information and are aware of the philosophy and principles of care. Provision of current, coordinated plan of care. As described in Section 483.70N4, the intent of this regulation is to ensure coordination of care between the nursing home and the hospice in order to assure that the most current plans of care for each resident have been coordinated, individualized, and identify what each entity will provide. Key elements of noncompliance. To cite deficient practice at F849, the surveyor's investigation will generally show that the facility failed to do any one of the following: develop a written agreement with the Medicare-certified hospice prior to hospice services being provided to a resident, or establish a communication process, including how the communication will be documented between the LTC facility and the hospice provider to ensure that the needs of the resident are addressed and met 24 hours per day, or, in accordance with the written agreement, to immediately notify the hospice about a significant change in the resident's condition or the presence of clinical complications that suggest a need to alter the plan of care or a need to transfer the resident from the facility or of the resident's death, or to designate a member of the facility's interdisciplinary team who is responsible for working with hospice representatives to coordinate care to the resident provided by the LTC facility staff and hospice staff, or ensure that each resident's written plan of care includes both the most recent hospice plan of care and a description of the services furnished by the LTC facility to attain or maintain the resident's highest practicable physical, mental, and psychosocial well-being, or delineate the responsibilities of the hospice and the LTC facility to provide bereavement services to LTC facility staff. If there are concerns with the implementation of care or services by the hospice provider, then the survey team must refer the complaint to the state agency responsible for oversight of hospice, identifying the specific residentess involved and the concerns identified. Investigative summary. Use the hospice and end-of-life care and services critical element C pathway, along with the interpretive guidelines when determining if the facility meets the requirements for providing care and services for a resident receiving hospice services. In accordance with professional standards of practice, the coordinated person-centered care plan. In addition, the services must be and based upon the requirements included in the written agreement between the nursing home and hospice. Summary of investigative procedure. Briefly review the most recent comprehensive assessments, coordinated care plan, and orders to identify whether the facility has recognized, assessed, provided interventions, and implemented care and services according to professional standards of practice, in order to meet the resident's hospice care needs. This information will guide observations and interviews to be made in order to corroborate concerns identified. In addition, investigate to assure that there are sufficient numbers of trained, qualified, and competent staff to provide the interventions identified for a resident receiving hospice care and services. If concerns are identified, review the appropriate sections of the written agreement above. If the resident has been in the facility for less than 14 days before completion of all the resident assessment instrument RI is required, review the baseline care plan, which must be completed within 48 hours to determine if the facility is providing appropriate care and services based on information available at the time of admission. In addition, review to determine whether the comprehensive care plan is evaluated and revised based on the resident's response to interventions. Note, always observe for visual cues of psychosocial distress and harm. See Appendix P. Guidance on severity and scope levels and psychosocial outcomes severity guide. If a concern is identified during the survey regarding hospice care and or the timeliness of the hospice services, the survey team should review how the nursing home's QAA committee is monitoring the provision of hospice services, such as monitoring the response by the hospice for the timely provision of care, including on-site visits by hospice staff during a crisis or change in the resident's condition. If noncompliance is identified related to the written agreement, cite at F849. If noncompliance is identified related to quality of care, cite at F685, quality of care. Deficiency categorization. Examples of Level 4, immediate jeopardy to resident health and safety, include, but are not limited to: the failure of the facility to assure that the resident received hospice care and services based upon a written agreement with a Medicare-certified hospice. For example, a deficiency was cited at severity level 4 at F697 when the resident has severe uncontrolled pain, or F675, acute respiratory distress, and at F849, the facility fails to contact and consult with the hospice as per the written agreement for a change in condition. The facility failed to establish a written agreement with a Medicare-certified hospice that was allowed to provide hospice services in the nursing home. In this example, a deficiency was cited at severity level 4 at F697 when the resident was administered medication for pain management by the hospice, and due to lack of coordination, the nursing home, unaware of the administration of the medication, also administered pain medication, resulting in an overdose of opioids and hospitalization due to acute respiratory failure. And at F849, the facility failed to establish a written agreement with a Medicare-certified hospice that was allowed to provide hospice services in the nursing home, resulting in the lack of coordination. Examples of Level 3, actual harm physical or psychological that is not immediate jeopardy include, but are not limited to: the failure of the facility to assure that the resident received hospice care and services based upon a written agreement with a Medicare-certified hospice. For example, a deficiency was cited at severity level 3 at F697 when the resident has experienced pain that compromised his or her function physical and / or psychosocial and / or ability to reach his or her highest practicable well-being as a result of the facility's failure to recognize or address the situation, or failure to develop, implement, monitor, or modify a pain management plan to try to meet the resident's needs. For example, the pain was intense enough that the resident experienced recurrent insomnia or reduced ability to move and perform ADLs, or a decline in mood or reduced ability to communicate / socialize with family and / or participation in activities. And at F849, the facility failed to contact and consult with the hospice as per the written agreement for reviewing the resident's care plan for pain management. At F849, the facility failed to establish a written agreement with a Medicare certified hospice that was allowed to provide hospice services in the nursing home. In addition, the facility failed to contact and consult with the hospice for concerns related to significant changes in the resident's physical condition or need to alter the plan of care, which is a component of the written agreement regulation. For example, a deficiency was cited at severity level 3 at F697 when a resident experienced significant episodic pain that was not all-consuming or overwhelming, but was greater than minimal discomfort too. The resident related to care / treatment, such as prior to wound care, exercise, or physical therapy. The facility failed to involve the hospice and failed to develop, implement, monitor, or modify pain management interventions. Examples of Level 2, no actual harm with a potential for more than minimal harm that is not immediate jeopardy include, but are not limited to: the failure of the facility to assure that the resident received hospice care and services based upon a written agreement with a Medicare-certified hospice. For example, a deficiency was cited at severity level 2 at F697 when the resident was on a pain management program utilizing opioids. The resident was experiencing episodic minimal discomfort, and the facility failed to consult with the hospice regarding the bowel management plan as identified in the coordinated plan of care. The facility was cited at F849 for failure to contact and consult with the hospice as per the written agreement for communicating with the hospice for review and possible revision of the resident's care plan. At F849, the facility failed to establish a written agreement with a Medicare certified hospice that was allowed to provide hospice services in the nursing home. In addition, the facility failed to contact and consult with the hospice for concerns related to a need to alter the plan of care, which is a component of the written agreement regulation. For example, a deficiency was cited at severity level 2 at F697 when a resident experienced daily or less than daily discomfort with no compromise in physical, mental, or psychosocial functioning as a result of the facility's failure to adequately recognize or address the pain management. The resident was able to participate in ADLs, and / or activities of choice. The facility failed to involve the hospice in developing, implementing, monitoring, or modifying pain management interventions. The facility failed to assure that the written agreement met one or more of the regulatory specifications, resulting in the potential for negative resident outcomes. An example of Level 1, no actual harm with a potential for minimal harm, includes, but is not limited to, there are components of the written agreement that were not met, but they may have minimal impact to the resident. Failure to meet these elements will be cited at severity level 1. For example, the facility failed to implement provisions of the agreement regarding bereavement services for the LTC. Potential tags for additional investigation section 483.70N hospice services. If an additional concern has been identified, the surveyor must investigate the identified concern. Do not cite any related or associated requirements before first conducting an investigation to determine compliance or noncompliance with the related or associated requirement. Some examples include, but are not limited to, the following. Section 42, CFR Section 483.21b1, F835, Comprehensive Care Plans. Section 42, CFR Section 483.21b2, F857, Comprehensive Care Plan Revision. Section 42, CFR Section 483.25, F885, Quality of Care. Section 42, CFR Section 483.40d, F845, Medically Related Social Services. Section 42, CFR Section 483.70g, F841, Medical Director. Section 42, CFR Section 483.70H5, F842, Resident Records, and Section 42, CFR Section 483.75CHI, F866, Section 483.7, 5DEG 2 Roman 2 Roman 3 F, 867 Quality Assessment and Assurance. Tag F850. Section 483.700, Social Worker. Any facility with more than 120 beds must employ a qualified social worker on a full-time basis. A qualified social worker is Section 483.7001, an individual with a minimum of a bachelor's degree in social work, or a bachelor's degree in a human services field including, but not limited to, sociology, gerontology, special education, rehabilitation counseling, and psychology, and Section 483.7002, 1 year of supervised social work experience in a health care setting. Working directly with individuals. Guidance Section 483.700. The regulations do not require a social worker when a facility has equal to or less than 120 beds. If the facility has more than 120 beds and its full-time social worker does not provide on site coverage on a full-time basis, determine how these services are provided to meet the individual needs of the resident whenever needed. If social services deficiencies are identified, refer to Section 483.40d, F845, regardless of the number of beds. Key elements of noncompliance. To cite deficient practice at F850, the surveyor's investigation will generally show that the facility failed to do any one of the following. A facility with more than 120 beds did not employ a qualified social worker on a full-time basis, or the individual functioning as the social worker did not meet the qualifications specified in this regulation. Tag F851. Section 483.7. 0P Mandatory submission of staffing information based on payroll data in a uniform format. Long-term care facilities must electronically submit to CMS complete and accurate direct care staffing information, including information for agency and contract staff based on payroll and other verifiable and auditable data in a uniform format, according to specifications established by CMS. Section 483.7. 0P1 Direct care staff. Direct care staff are those individuals who, through interpersonal contact with residents or resident care management, provide care and services to allow residents to attain or maintain the highest practicable physical, mental, and psychosocial well-being. Direct care staff does not include individuals whose primary duty is maintaining the physical environment of the long-term care facility, for example, housekeeping. Section 483.7. 0P2 Submission Requirements. The facility must electronically submit to CMS complete and accurate direct care staffing information, including the following: I. The category of work for each person on direct care staff, including, but not limited to, whether the individual is a registered nurse, licensed practical nurse, licensed vocational nurse, certified nursing assistant, therapist, or other type of medical personnel, as specified by CMS. Roman II Resident Census data, and Roman III Information on direct care staff turnover and tenure, and on the hours of care provided by each category of staff per resident per day, including, but not limited to, start date, end date as applicable, and hours worked for each individual. Section 483.7. 0P3 Distinguishing employee from agency and contract staff. When reporting information about direct care staff, the facility must specify whether the individual is an employee of the facility or is engaged by the facility under contract or through an agency. Section 483.7. 0P4 Data Format. The facility must submit direct care staffing information in the uniform format specified by CMS. Section 483.7. 0P5 Submission Schedule. The facility must submit direct care staffing information on the schedule specified by CMS, but no less frequently than quarterly. Intent Section 483.70P. To ensure that long-term care facilities are electronically submitting direct care staffing information, including agency and contract staff per day, based on payroll and other verifiable and auditable data, the staffing hours, when combined with census information, can then be used to not only report on the level of staff in each nursing home, but also to report on employee turnover and tenure. Guidance Section 483.70P. The facility is responsible for ensuring all staffing data entered in the payroll-based Journal PBJ system is auditable and able to be verified through either payroll, invoices, and / or tied back to a contract. The surveyors can obtain PBJ data from the certification and survey provider enhanced reports Casper report to determine if the facility submitted the required staffing information based on payroll data in a uniform format. The facility's failure to submit PBJ data as required will be reflected on their Casper report and result in a deficiency citation. If concerns were identified based on the Casper report or from any other source, refer to the critical element pathway, sufficient and competent staffing. Refer to the CMS Electronic Staffing Data Submission, Payroll-Based Journal Policy Manual for Submission Guidelines. Please see the following link for more information. https://www.cms.gov/Medicare/Quality Initiatives Patient Assessment. Instrument/nursing home quality, init/staffing dare submission pbj.html. For questions related to F851, surveyors, providers, or other stakeholders should email nhstaffing@cmshhs.gov. Key elements of noncompliance. To cite deficient practice at F851, the surveyor's investigation will generally show that the facility failed to do any one of the following: complete data for the entire reporting period, such as hours paid for all required, staff each day, or provide accurate data, or provide data by the required deadline, or submit the required staffing information based on payroll data in a uniform format. Noncompliance at F851 focuses on the submission of staffing data. If the surveyor identifies concerns related to sufficient staffing, surveyors would investigate these concerns using the sufficient and competent staff critical element pathway and guidance at Section 483.35, Nursing Services, F725, and F727. This concludes the reading of Appendix PP. Regulation Section 483.70, tags F835 through F851.